Well, we're going to talk about stuff today to help you better, wait, got to turn this on, there we go. To help you improve your programs of safety and help stop or reduce the amount of violence that's going on in our hospitals. So before we get to that, I want to ask you a question. What does a high school, your first day in college, and your dorm, an airport, and a hospital have in common? Be more specific.
People coming and going.
People coming and going. How about people with a lot of anxiety? A lot of nervous, a lot of scared people, right? So in each one of those situations, if you can think back, I can't think back that far, but your first day in high school, right? You're coming from that middle school and you're going into where the big kids are, right? That's a scary day. That's my youngest son. That's his first day in college, right? His first day in his dorm. Think about that first night by yourself in your dormitory. Then you go to the airport. Now, I fly a lot. Anybody here fly? Anybody fly? Have you flown recently? So you get a couple of different kinds of people in the airport. You get the business people. I know where I'm going. Don't get in my way. Stay out of the hallways. That's business people, right? Then you get the vacationers. Looking around, standing still. Then you get the people that work there. And as they go from their one gate to the other gate, they just kind of stroll and chat, right? It's their place of business. They're there every single day. So you mix all those different levels of anxiety together, and you can have some conflict, right? Right? Get out of my way. I'm trying to get to my gate, and you're just lollygagging, right? I can't believe I just used that word. Anyway, then we're here at a hospital. Same thing. Same exact thing. You have people who work there. Healthcare is every day for them. It's nothing new to them. We use words like routine procedures, right? Then you get the people who are coming in as patients that the anxiety level's already here, and you tell them, you're going to have a routine procedure that's not routine to them. And then you have visitors, and they're a breed all their own, right? All those visitors. And you mix them all together, and you have a nice cauldron of explosive material. And we're going to talk about that and how we get past that. All right, so let's talk about assessments. Why do we do an assessment? Anybody? Why? Why do we do one?
Opportunities for improvement.
Opportunity for improvement. Okay. Let me give you this. Here are the words that you can use to your executive leaders and your clinical leadership of why we do an assessment. All of these are valid. All of these are true. And by the way, they are getting copies of this, right?
Yes.
Okay. So in the notes section of these slides, I've put a lot of information so that you can go back and look at these slides and say, we need to do an assessment. Let me give you the verbiage to use to promote why you need to do an assessment. So for each of these bullet points, there's a whole paragraph of information in there for it. But these are the things you talk to your leadership about, right? And if you're leadership, these are things that would register with you. Then, the goals. What is your goal of the assessment? Now, I do a lot of assessments. Lisa does a lot of assessments. The first thing we do is we sit down and we ask, what are you trying to get out of this assessment? Well, we want an assessment. But what are you trying to get to? What are you trying to reach? Because every type of assessment that you do, the way you ask the questions that you ask, you're going to gear it towards a certain group of solutions. Does that make sense? So if you're doing just a general security assessment, you're going to start looking at physical attributes. If you're looking at a workplace violence assessment, you're looking at a lot of other things. Hopefully all that makes sense. But think about the goal of the assessment that you're trying to do. But in reality, the goal of our assessment is this. I'm not going to stand here and quote data that you already know. We already know that nurses and clinical staff are getting harder and harder to hire. Retention is getting harder and harder. Violence in hospitals is on the rise, not on the decline. So why Would we want someone to come work in that environment? But more importantly, why would we expect someone to come into that environment knowing that there is violence and experiencing that level of violence? So the purpose of your assessment is to empower the hands that heal. Keep the folks who are doing the job safe. And I love the picture on the right. You have the confrontation, the physical confrontation going on, but look around them. You not only have to explain this violence to those three people, but what about the staff members that are now looking on? What about the other patients that are hearing and seeing the commotion that's happening? How do you address that? How do you take that into account when you start looking at your brand image? I guarantee you that as you try to recruit staff, they already know what kind of culture you have at your hospital because they talk. They talk to other people. They talk to people who've worked there in the past. They talk to people who work there now, right? Healthcare is a very close-knit society. We know what hospitals are safe and what aren't without you doing an assessment. So the fact of you doing an assessment is to bring to light what most people already know. Does that make sense? Okay. The who. Who does the assessment? So you can approach this in a couple of different ways. You can do it. If you do it, you need to do it as a team. If I do it, right, if I'm in my hospital and I do the assessment by myself, I'm very biased. I have blinders on because my blinders are based on my experiences. It's not based off of everyone else. But if I took everyone at this table and I said, you know what, we're going to do it together. I'm bringing in your backgrounds, your experience levels, what you've noticed in your day-to-day. And you bring that to the assessment process because you're going to see things I don't. You're going to see things in a different context that I do. And conversely, I'm going to see things in a different context than you do. You may go up to a door and you may go, oh, well, that's just a door. I'm going to go up to a door and I'm going to say, is this door bullet resistant? Does this door have hinges where I could use to commit suicide? What does this door mean to me versus what it means to you? Does that make sense? Okay, I usually say, does that make sense? And I apologize up at front. It's just my way of gauging you. So if I say, does that make sense? And you're back there doing this, I know that I'm really not engaging. So hopefully that makes sense. Okay, so let's get people involved, right? So get all these folks involved. The three at the bottom. Let's talk about the three at the bottom because these are specialized. Remember what I said about blinders. We all have blinders based off of our knowledge and our experience. So the very first one, local law enforcement. Is it good to have local law enforcement involved in your workplace violence assessment? Yes, it is. But you need to understand where they're coming from. They are not familiar with a healthcare environment. They don't know the environment of care. They look at things through their lens of law enforcement and protection and criminal activity. So please involve them, but know what their biases are. When you look at a consultant, and we'll talk more about consultants in a few minutes, you want to be very wary of consultants and who you're hiring. Be very cautious of who you're hiring. And I'll give you some tips on what to look for when you're looking at consultants. Union reps, do you guys have to deal with unions here? Okay, so if you ever do, you may want to involve a union rep. Anybody use Joint Commission? Okay, if you look at, there's a standard in Joint Commission that talks about if you have a transplant program. And if you have a transplant program, you have to involve the organization, the organ procurement organization, when you start looking at your assessments. And the purpose of that is if things get disrupted, and we're talking on a grander scale, if things get disrupted, how are you going to continue on with that process? Make sense? Sort of? It's Joint Commission. Okay. Any questions about these so far? Wow, it's a quiet bunch, and it's the beginning of the morning. All right. When you do your assessment, the first thing you need to have when you do an assessment is a checklist. There are a lot of places to get checklists. You can get them from OSHA, you can get them from the American Nurses Association, you can get them from the American Hospital Association, you can get them from your hospital association. And there's two that we're providing you. One is in your packet, right, Michelle? It's in the packet. That one in your packet is a simple 3-page assessment, and we'll talk about it in a second. There's one on the portal on your website that is 106 pages. Yeah. So if you really want to get in the nit and gritty of a security assessment, pull up the 106-page one, and it has everything on there from NFPA 99, NFPA 101, OSHA, Joint Commission, CMS, DMV, everything's in there. I don't expect you guys to go and pull a 106-page assessment and start doing a security assessment. Let's start with a 3-pager, and it kind of gives you an idea of what it is you're looking for. And we'll go over that in a second. But if you're going to use a consultant, here's my advice to you on a consultant. One, make sure they have a good reputation. Check their references. Talk to other hospitals that have used them. Talk to people who've hired them in the past. And the questions that you want to ask are, what's their knowledge level? How well do they know the laws and the rules and the standards in healthcare that apply to you? The second thing is, after you check references, you want to interview them. It's really important that you get along with your consultant and that you're on the same page of what the goal is with your consultant. Because if you have a consultant that comes in with their own agenda, with their own ideas, and you haven't given them what your goals are, then you're not going to get the product that you were looking for. So please make sure you interview and have that conversation and discuss the purpose and the goals of your assessment. Now, if you don't know the purpose and the goal of your assessment, sit down with a consultant and talk about it. Maybe they can help you develop your purpose and your goals of why you're doing this assessment. That's a good conversation before you decide on whether or not you hire a consultant, okay? All right. Step one on doing your assessment. Gather information. And that information is going to come from a lot of different spots and a lot of different places, and you're going to have to talk to a lot of different people when you gather your information. And when you look at your security assessment, you're going to look at it from two different perspectives. What is the perception of security and safety versus what is the reality of security and safety? And here's what I mean by that. Let's say the reality. How many crimes have you had committed on your campus? How many incidents of violence have you had committed on your campus? That's reality. But the perception could be completely different. I was in one hospital, they had one incident of violence in the past 6 months. Let me rephrase that. They had one reported incidence of violence in the last 6 months. So on the surface, it did not appear as though there was a lot going on in this hospital. You start talking to people, you start digging into it, and you find out that one incidence of violence is more like one incidence of violence every couple of days. They just didn't report it. Or they didn't, and why didn't they report it? That's another question you want to dig deeper into, right? What was prohibiting you from reporting that incident? And it could be the culture is we accept the violence. It's part of our job. Another is, well, the tool we have to report it is so difficult and cumbersome that it takes too long to do it. So somewhere in there, you're going to find what those obstacles are to finding out the truth about what's going on in your facility as it pertains to violence. But the only way you're going to get there is you have to talk to people. So when I go, I walk around a hospital and I just sit down and I start talking to people. And I don't sit down and go, how safe is your hospital? Hi, how are you? What do you do here? Tell me about your job. How often do you work? What time, what hours do you work? Do you always work on this shift? Do you always work on this unit? Get to know them a little bit. And then start talking about, well, tell me about some incidents that have kind of upset you. Or maybe tell me some incidents that you've encountered that made you a little cautious. And if you use those words, upset you and cautious, as opposed to fear or assault, you're going to start to hear a little bit more. Now, if you were here last year, you probably heard this story, but I have 6 aunts on my mom's side. They're all nurses. So I'm going to say this with relative certainty. Telegraph, telephone, tele-nurse, because they all communicate with each other. So one thing happens to one nurse in Washington State. Well, it's in Florida by the end of the week. Right? That communication network is vast. That's great, but it also provides this little bit of interesting causation. An incident occurs, and by the way, there were 2 incidents in the news yesterday. An incident occurs at one hospital, maybe not even in your town, maybe not even in your state, and they hear about it. What do they start thinking? Could that apply here? Could that happen here? What are we going to do when that happens here? So when you start asking questions about what makes you uncomfortable, you may not have incidents that are occurring at your facility, but there may be incidents that they're hearing about, and they don't know how you're preventing them in your facility. So that's another obstacle. That other obstacle is, are you allowing folks to know what you're doing to prevent the violence? Are you getting them engaged and interactive so that they understand your workplace violence prevention program? Right? So that all of this comes into the perception. You also want to talk to your HR. You want to talk to your recruiters. What are they hearing? So in HR, hopefully you're doing exit interviews, or maybe they're not. Maybe they're hearing things that are occurring. What are the reasons why people are leaving your facility? Talk to your recruiters. What are the challenges you're having in recruiting more people to come to your hospital? What does that look like? And then lastly, do I have the tools? And this comes back to, do I have the ability to report violence that's occurring without the fear of retribution? Do I have the ability to report the violence that's occurring without it taking 20 minutes to fill out a form or to log into a computer and go through all the steps to report it? Do I have the tools to let management know what's happening on the unit? So look at those.
So one thing before he leaves, perception, that I think is really important, and because I'm a woman, I feel like that I have a different or a little more unique view, than Mike. Perception is reality. Perception is reality. And I've had predominantly male coworkers, male individuals, police and security that have worked, under my direction over the years, and the first thing they would say is, they just get so excited. It was nothing. The guy raised his voice. Really, it's nothing to even get worried about. I don't know why they're like that. And I really had to kind of sit down and have those conversations and want to really push you to be respectful that their perception is reality. So I know that we don't always think of that, and I know I got a little hardened to it upon occasion too. It's like, oh no, this same person, if someone doesn't sit properly in the emergency department, she calls for a check-in. You need to come and watch this individual. They're going to become violent. But understand there's a reason that these individuals feel that way. So I just wanted to kind of add that, Mike. Thank you.
I got a phone call last week from one of our hospitals in Florida, and it was from a nurse manager. She's been around a while. She's a nurse manager, and she wanted to tell me about an incident that occurred. They have a patient. It's a long-term care facility. They have a patient that's been there a long time. The son of the patient is a little more aggressive than people would like. Mannerism, the way they speak, things like, "Why did my mom not get the medication when I wanted it?" Right? That's the approach that that son has. So she calls me, she says, "Mike, I need to do something. I don't know what to do. I'm really scared." Tell me what happened. She got to work, she got out of her car, and as she was walking to the hospital, the son aggressively approached her and threatened her. Okay, what did he say to you? Well, it wasn't much what he said, it's how he said it. It was the way he said it, the mannerisms in which he did. So here's a caution. Don't read a security report and blow it off thinking what Lisa just said, right? He just approached her in the parking lot. If I was not hearing this directly from that person, I would have heard no threat was made, no threat was communicated, there was no violence. He just asked when when his mom was going to get discharged. Discharge was the whole issue. That was it. But when you hear it from the person who experienced it, now the pages become more colorful. We start to hear what that did to that person. So when Lisa says perception is reality, and you all know that's true, I just wanted to paint you a picture. Because that picture, when you listen to what they say to you and how they say it, changes everything. When you go, and here's another difference between our job and what we do and law enforcement. So she called law enforcement, and what do you think they said?
No threat.
No threat. There was no threat communicated. We'll do a report for you, but no threat was communicated. Okay, because they deal in the law and they deal in crime. And from their perspective, no threat was communicated. But does that lessen the impact on that nurse? Does that lessen the impact of her perception of safety and her job? No. So now we need to take all of those into account when we're doing our assessment of the situation. By the way, yes, you can do assessments of situations versus an overall assessment. Data. Thank you, Lisa, by the way. Data. When you're looking at data, you want to look at, and hopefully you're tracking now, incidents of workplace violence. Hopefully you're tracking when those are occurring and what type of violence and where those are occurring. So look at your data, see what kind of trending you're doing. Please don't do this. Everybody has a safety committee or environmental care committee or whatever the committee is, and you meet once a month and you go, okay, workplace violence. Did we have any incidents of workplace violence? Yeah, we had 3. Okay, next, infection control. Who's up? Let's pause. You had 3 incidents of workplace violence. Can we talk a little bit about that? It's all in the story. I know you don't have a lot of time in these meetings, but paint the picture very quickly. Let's do a comparative analysis. You had 3. How does that compare to the previous month? What are you seeing over a 12-month period? Where did this occur? What time of day did this occur? Or did these incidents occur? Are you seeing trending? How is this impacting the staff of that unit or those units? So don't just look at raw numbers. Look at how it is developing. And those numbers can help you see that. Also look at workers' comp and injuries. Remember I said very few people, we have a problem with reporting violence. Go to HR, whoever is tracking your workers' comp. Start looking at workers' comp and how much you're spending on injuries for workers' comp. Use that as your baseline for your program. Follow that year after year, and you may see some improvement based on the program that you put into play. But that will help you. Look at your staffing. Overtime. Where are you seeing a lot of overtime? Why is it you're seeing a lot of overtime in those locations? What is the root cause of all the overtime that you're seeing in certain departments? And all of that together, with your perceptions, with your staff surveys, with your talking, all of this now creates a story for you, and that's where your assessment really comes to life, because you start putting it all together. Step 2, review the physical environment. Perception is reality. If I walk into work, let me back up. If I pull into work and I pull into the parking lot and it's dark and only 3 lamps out of 20 are working, I may not cognitively go, there's only 3 out of 20 working, but I do know it's dark. It's not well lit. Do you know there are 3 things that people are very afraid of? Can you guys guess what they are? What are the 3 things people are afraid of? Public speaking, number 1. What?
Being ambushed.
Being ambushed, okay. Violence, right? So public speaking is number 1. Dentists are number 2. And violent encounters, right? So those are your top 3. So that perception of I have to park in a dark spot, I have to park where I can't see or where I'm fearful. More people are afraid of the dark than during the light of day. A lot of mistakes are made when we do assessments. They come in during the day, Monday through Friday, 8 to 5. Yeah, that's not who the fearful people are. We need to do that off hours. Let's do that at night. Let's do that in the darkness. Talk to those folks. Look at those lights. How are they getting into the hospital? What are they passing as they come into your hospital? I was at one facility and they're like, you know, people don't like parking in our parking lots and they complain about it all the time. Well, when I drove up, I noticed that all the garbage cans were overflowing. There was graffiti on several walls. I'm like, you wonder? None of the lights worked. You wonder why people are afraid? You got to look at this from a broader perspective than Monday through Friday, 8 to 5. Hiding spots. You're going to hear a lot of stuff, especially in the video, where we talk about the design of your exterior. Crime prevention through environmental design is a big deal, and it means a lot. And it's talking about things like when you have bushes, and you put those bushes and you allow them to be 6 feet tall and 20 feet wide, and they cover your windows, and it allows a lot of hiding places. If you have bushes like that, go look through them. Go look on the ground behind them and see. You may end up seeing signs of human activity. I won't describe the human activity, but you may see signs of human activity behind those bushes. You may find things hidden. I was at one facility and went behind one of the bushes at the main entrance. There was a firearm just sitting kind of underneath a little, it was an old ratty t-shirt. Someone had hidden a firearm because they knew when they went into that emergency department, they couldn't have the gun. So they hid it outside. I found knives, I found all kinds of things in those bushes right outside entrances before you go in. So take a look at hiding spots. Lighting we talked about, entry points and camera coverage. What does your camera coverage look like? Can you pull off camera coverage that you can actually see someone's facial features? How many times have we seen on the evening news the camera coverage and you could barely tell it was a person? It could have been Sasquatch walking through there, right? You can't tell. Well, that means that camera coverage is not very good. You may have to upgrade those cameras a little bit. You want to be able to tell if you have a human or Sasquatch walking through your area, right? Makes sense.
I just want to mention, he mentioned the crime prevention through environmental design. Is there anyone in here that's ever heard of that? CEPTAD, outstanding. There's 4 main principles. There's the natural surveillance, and some of those things Mike talked about. You'll hear more about those later. There's natural access control. You'll hear more about that. Territorial reinforcement. And the last one, we throw that in there, but to me it's one of the most important. Mike mentioned, it's maintenance. Maintenance of all those things. And has anybody ever heard of the broken window theory? We've got at least one person that's heard of the broken window theory. If you've not, look it up. What it really pertains to is especially in cities. If there's a broken window in a place, whether it's a place of business, a home, and it goes on for a period of time, all of a sudden, that becomes a place where more crimes are going to occur, similar to the graffiti. But the maintenance is humongous. And I know a lot of you probably don't even pay as much attention to what a lot of your facilities folks, your landscape folks do, but that is huge. It's huge. So just wanted to kind of bring that out, Mike.
Thank you. Another thing to add to the broken window theory, cars in your parking lot. If you walk through your parking lot and you see a car that's got an inch of dust on it, that means that car hasn't moved for a long time. Why is that car there? Who does that car belong to? Make sure you're walking your lots. Make sure you're walking around to look and see what's here. There are hospitals that become dumping grounds for stolen cars. People steal them, they park them in your lot because they know that you don't have good cameras because it looks like Sasquatch walking through, or they just know they can dump the car there and get away and get away with it. So walk around, be observant, look for those signs that there's something out of place. Because if you notice it, guaranteed people in the community have already noticed it. So take a look at those. Now let's look at our interior. Let's start at the main door. How do we get in? Oh, let me back up for a second. Another thing that's very important in your exterior is, and it doesn't take a lot of money here, or I'm not talking a lot of a big cost, but look at your signs and look at your painting. And here's what I mean. Your stop signs. If your stop signs were installed in 1922 and they're faded and you can barely read stop on it, that's another sign that there's not a lot of maintenance going on, which means there's not a lot of activity going on, which means it's not a monitored area. Forget the liability of having a stop sign that nobody can read. That's another liability. But look at your stop signs, look at your signage, and see, does it look kept up? Look at the lines in your parking areas. Are they painted? Look in, did anybody have a parking structure or garage? Okay. Look at your garage. Is it dark and dingy? You know, a little bit of paint, light, bright yellow, white, does wonders for the light refraction and being able to lighten up those dark areas. So look at what it looks like from someone coming in. And here's where that crack in the sidewalk theory. We see a crack in the sidewalk, and every day we notice it less. Less and less and less, until we don't even see it at all. So try and come at it with a new, fresh set of eyes. The next time you go to your facility, when you drive up, think of it like you've never been there before. Where do I park? How do I get there? What are the impressions I'm seeing as I come in? And you'll start to see those little things that everybody else picks up when they first come to your hospital. And your staff see it every single day. Okay, coming inside, access control. How do we get into our facility? I get it. Not every hospital has the money to spend on electronic access control systems. I get that. But what you can do is make sure that you only have one or two entrances. You limit the amount of traffic that comes in. You limit the doors that people can use. If all of your doors to the outside are open and anybody can come in at any time, you're asking for violence. You're asking for someone to come in and rob you. So look at your access. Look at how people get in. Look at the flow of traffic. What are the best doors to have open? Are there times that you want to have them open or not? We have a lot of LTACs, and we close those LTACs at certain times every day, right? 8 o'clock, those doors are closed and locked. 8 o'clock. I have some LTACs where the doors are locked all the time, and you have to be buzzed to get in. Think about those. Think about why is it your doors are open. Then think about who is watching who's coming in your facility. We have a lot of hospitals where there are volunteers, and the volunteers are sitting in the front. Great, okay, you have volunteers there, don't stop there. When do the volunteers come in and when do they go? When do your doors unlock and when do they lock? What are the gaps in coverage? Well, don't stop there. When you talk to your volunteers, so what do you do? Well, I volunteer. Okay, but what do you do every day? What's your day look like? Well, I sit here, and people come in and I say hello to them, and I give them directions. There's a beauty to sitting back and watching. I was at one, and I just sat back and I watched the volunteers, and the only people they engaged were the people that approached them. So if you're just engaging the people that are approaching you, what about the rest of the folks? You don't know why they're there, you don't know where they're going, and you miss a golden opportunity for customer service. Someone walks in that door and your volunteer says, "Hey, welcome, how can I help you?" "Oh, I know where I'm going." "Great, where is that?" You have to teach them to be aware of their surroundings. Teach them the signs to look for. When we talk about de-escalation training, I hate that phrase, by the way. It's not just about de-escalating someone who's going off the rails. It's about observing people's actions and what they do and how they present themselves. Let me ask you a question. How many of you have ever been on a first date that failed? Oh, come on. Nobody? Okay. When you're on that first date that failed, we may have to think back a few decades, right? But when you're on that first date that failed, did you know pretty soon it was going to fail? Pretty quick? Yeah, no, I don't like the way they chew. I don't like, there's something, right? You're going to pick up on something. Whenever we have contact with another human being, we always pick up on something very quickly. Eye contact, lack of eye contact, mannerisms. We can tell when someone's nervous. If you open yourself up, everyone in this room, I'm just looking around real quick, everyone in this room has at least 20 years of observational experience in dealing with people. Tap into that. You know when someone's upset, you know when someone's acting cagey, you know when someone's acting weird. And there's nothing wrong with that. Observe it. Point it out. But we've got to talk to people and tell them, you're a volunteer, you're at the main door, you're the Walmart greeter of our hospital back when Walmart greeters were a thing. You're the person that is the representative, but you're also our first line of defense. You're the one that's going to recognize someone who's got escalating behavior when they come in the door and maybe sound the alarm if you feel as though it needs to be sounded. Sensitive areas. How many of us have units that we would consider sensitive that we don't control access to? ICUs, critical care units, mother-baby, right? We all have those little areas that we need to pay attention to of what we need to do to better people coming and going from those units. Then we look at lobbies, we're looking at hiding spots again. Look at patient rooms. And I'm going to wrap it up quick because I talk too much. When you look at a patient room, look at the room and how it's set up. If I walk in the door, pretend that's the patient's bed. If I walk in the door and I have to go around the patient to get to my workstation, where's my escape route? Through the patient. The patient can now block my exit very quickly. So look at your setup. And believe it or not, this is how most rooms are set up. I want you to put yourself in the position of the clinical person that has to go into that room. And it won't mean anything until the moment they get scared. Until the moment that patient says, "You pull that needle out, I'm going to punch you in your face." Then the alarm bells go off. Then they're like, what am I doing over here when the door is over here? So let's circumvent all of that. Take a look at your patient rooms and how they're set up. And I know they didn't talk about this during construction, and all kinds of things are constructed in a different way, but try and make it as angled as best you can where there's a direct line of sight to that door, and you can get out as fast as you can. So look at that as you're looking at things for those escape routes. Also look at that when you're looking at nurses' stations. What's your escape route? Look at it in lobbies. If you have a receptionist, what's their escape route? And they may not cognitively state, I don't feel safe because I don't have an escape route, but I guarantee you every time they're sitting there and someone raises their voice, they're thinking about it. So as you do your assessment, that's something you want to look at. Okay, the 3-page checklist. It's broken down into some sections. I'm not going to read over every one of these. It's designed for you to go through and just start the conversation. The very first one, are access controls in place and functioning? I walked into one hospital. Do you have access control? Yes, I do. Let's go to the pharmacy. Do you have access control into the pharmacy? Oh yeah, we have it's card access. Got a card reader, and you got to punch in a code to be able to go into the pharmacy. Really? Okay. Have you tested it lately? What do you mean? Well, have you tested it? It's right there. The light's green. It works. I walked into the pharmacy. All I had to do was turn the knob and walk into the pharmacy. Now, either someone had disabled the access control system, or it was not functioning. The mag lock was not working. But how are you going to know if you don't physically jiggle the doorknob? If you don't physically go up and check whether or not your access control systems are working? Exterior doors are famous for this. How many times do you have a mag lock on an exterior door that just stops? And if you're not periodically checking those, you're not going to know about it until it's too late, until there's an incident. So put that on your checklist. Do you have a visitor management policy? Are you following your visitor management policy? What does that look like? What are you able to do? Do you do visitor badges for folks? If not, how do you ID people that are coming in your door? That you have to determine based off of your risk. As you go through these, and I'm not going to go through all of them, you do want to make sure you're checking things that you don't normally check. I'll give you one more that is not on here. I was at a hospital, and the mother-baby unit was on the ground floor. And they had these big, beautiful floor-to-ceiling windows. Gorgeous. The light just comes in. There's this little beautiful little area outside with all kinds of plants and pretty little trees. It was gorgeous. And I walked over to the window, and it had a handle. And I turned the handle, and I opened the window. And I don't mean I opened the window. I opened the window, and I could use it as a door. And the facility manager said, oh yeah, we had those and we used those when we were bringing in furniture and stuff. It was easier to come in this way than it was to, well, how long ago were you doing that? About 2 years ago. So now on your ground floor, you have all these windows and all these rooms that open wide open as a door, and nobody even really knew about it or thought about it. The nurses didn't know. So go through and take a look at things that you may not normally look at because you haven't thought about them in a long time. When I say security personnel, not everybody has security personnel, but you do. When I say security personnel, who responds to your codes? Who responds to your incidents? Some hospitals, everybody, right? We get a code, everybody goes. Well, then everybody's part of your security program. Think of it that way. So when you look at that, is there a primary point person responsible to make sure that those people responding know how to respond, when to respond, and what to do? Or is it a cluster when you call for, what's a code when you have a violent person?
Code man.
Code man. That's sexist. Don't record that part. Code man. All right, your code. Your code for a violent person. When you call the code for a violent person, who responds and how do they respond? Do you have 1 million people show up? Do you have 5 people show up? Do you have 1 person show up? When they show up, what are they doing when they show up? That's important. What are they doing? If you're like a lot of hospitals, a lot of people show up. And when they show up, they go, what's happening? What are they doing? What is the purpose of you responding? Why are you going to this event? And what is your job when you get there? You should have 1 person in charge, and that 1 person should be the traffic cop. Okay, we have 5 people here. The rest of you get. Sorry, my southern comes out every once in a while. Get. We don't need you, or step aside. Or you have 20 people who are responding and you need them all. But then you've got to dictate what's happening. Do you remember anybody ever take CPR? Right, what's one of the first things that you do? You're the person in charge, you're about to do CPR. What's one of the first things you do? You point to someone and tell them what?
Scene safe.
Not where I'm going, but that's good. Call 911, right? Call 911. That's one of the first things that you do. Same thing here. If you feel more response is needed, designate someone, point to them and say, call the code, call the police. That way, you don't stand around going, someone should call the police. I wonder who called the police. Did you call the police? No, I didn't call them either. 20 minutes later, someone figures out you might want to call the police. So think about that role of who's responding, why they're responding, what is your purpose for being there. And then here's the critical one. What training have they had to respond? What have you done? And I don't mean training in a past life. I mean training that you have provided in your facility that's your expectation for their role and what they are to do. Think about that instead of a free-for-all. Because when it gets physical, you don't want a free-for-all. That's where people get hurt. You really have to have a coordinated, designated attack. Okay. Policies and procedures. Do you have a policy? Do you have a workplace violence prevention policy? Do you have a security policy? Do you have an environment of care policy? Is your policy current? Is it signed off on? Is it accessible to the folks in your hospital? And more importantly, is it real? Or is it just words on paper? Because words on paper will get you into trouble more times than not, especially if you're not training to it and if it's not what you do. I was at one, I've got the policy in my hand, called the code just to see what would happen. They called the code, I'm watching, that ain't in here. That ain't in here. They completely took this policy and had no regard for it whatsoever. So either one of two things. Either the policy was not adequate and didn't contain or cover what was to be done, or they were just doing what they want. So you've got to make sure you're in line with your teachings and your policies and what you're doing. It's like a tripod. All three have to be there to support what you're doing. You also want to make sure, and I'm jumping all the way down here to the bottom, second from the bottom. We have a lot of people that come into our hospital, that work in our hospital, that are not our people. We have contractors, right? We have vendors. We have all kinds of people coming in. Do they know what to do when you have an incident? And what if that incident involves them versus if it doesn't involve them? Now, I've seen some places, if you're a vendor and you see escalating violence, I need you to step out and report it to somebody. That's all I want you to do. Or, I want you to engage. That's up to you. But remember this, if they engage, you need to make sure they engage the way you want them to engage. How do you want them to do what you're asking them to do? So think about those as you go through your checklist. Risk identification, mitigation. This goes back to what have you discovered in the past? What did you do about it? I'm not going to mention hospitals. I went to one hospital. They have a security staff. They're in-house, they're not contracted, but they have a security staff. They're armed security staff. It is a small hospital, but they felt as though because of the area they were in, they needed an armed security staff. Okay, what are your qualifications for hiring someone into this position? Well, we prefer that they have a military or police background. You prefer that they have a law enforcement military. Okay, all right, I got that. All right. What qualifications do you make sure they have? What certifications, qualifications do you make sure they have before they start work? None? Okay. Do you do any weapons qualification? Oh yeah, we go to the range every December. So if I get hired in January, you're not going to know I can shoot until December. Right. Is that smart? What do you think? Anybody see holes in that? What standards do you have on the firearms that they're carrying? None. How many of you know firearms? How many of you know the difference between a 38 and a 44? One guy had a 38. One guy had a Desert Eagle 44 that was bigger than he was. What are you carrying? Desert Eagle 44, hollow points, 127 grain. It's bigger than you are. Why do you have that weapon? Why do you have that firearm? Why do you have that caliber? Why do you have that ammo? If you're going to do something, and I'm using an extreme point here, but no matter what you're putting into play, whatever you're doing, have a purpose for why you're doing it. Think about the caliber of that weapon. A 44 goes through not one wall, not two walls, but three walls and a couple of people, right? Is that what you want in a hospital? There's a difference between ball ammo and hollow points and what can happen as it goes through. But let's forget that for a second. Let's talk about cameras. Why do you have cameras? What is the purpose of that camera? I went to one hospital, I'm looking at their cameras, and I'm like, there's something wrong with this camera right here. It's kind of a white background. Oh, yeah, that's the camera by the loading dock. It's pointed at the wall. Why? Why do you have a camera pointing? Well, they installed the wall, but they didn't move the camera. How long ago? About 2 years ago. So you have a camera that is completely useless to you that's looking at a wall. And I mean, it wasn't looking at a wall like it's back here looking at that wall. It was like right here looking at a wall. So look at the purpose of what you're doing. Be frugal with the money that you're spending. We hear that all the time, right? We got to be conscious of the money that we're spending. So when you want to put something in place, you need to think about, what is the purpose of this device? Why do I need it? And technology, oh, those salespeople, they're good. They're good. I went to one hospital in Andalusia, Alabama, and that sales guy was good. They had 104 cameras. And they were proud. We have 104 cameras. They didn't need 104 cameras. They needed maybe 20. They had 4 cameras on one hallway, pointing in the same direction. Well, this camera does this, and this camera does this, and the sales guy says this camera can do that. Think about the purpose of the device that you're buying. Same goes for access control, same goes for locks, same goes for everything that you're doing, and buy the right thing for the right purpose. And as you go through doing your risk assessment, you want to make sure that you've looked at the purpose for all of these things that you're doing. Does that make sense? Yes? No? I'm confused as to why I'm sitting here? No? No? Okay. Emergency preparedness and response. There's a blending together of security and emergency preparedness. You want to make sure that those folks who are responding to security events also understand their role when it comes to other types of emergencies and what it is they're supposed to be doing, what it is they'll be tasked with doing. It could be everything from crowd control. Had an incident, there was a parade. In this parade, 8 people were shot. There was only one hospital nearby, so all 8 victims go to one hospital. Do you know what the crowd was trying to get into that hospital? There were 150, 200 people outside that hospital door trying to get in. They had one security officer on duty. Okay, that's the norm. But what did that security officer do? They panicked. They had no idea what to do. So they went into their office and started watching cameras. They didn't make any phone calls. They didn't alert anybody. They didn't call for help. And now all of a sudden you got tons of people coming into your emergency department waiting area. They're getting into your hospital through every open door they can find. So make sure that if you have just one person on duty, or if you just have no security but a person in charge, make sure they know what to do. Make sure they know how to sound the alarm. That's part of your assessment. Are they aware of not only who to call, but how to call them? How do I call for the backup to come? Okay. We're going to get, there's a lot of stuff about staff and patient safety and documentation, continuous improvement, so look through those sections. You want to make sure that you're looking at those sections and you're looking at how those apply to your facility and how that applies to your security program. You want to make sure that when you do your assessments that you are properly documenting it, and then what do you do with it? You got all this stuff together, you put it into a report. What are you going to do with that? Sorry, we're going to get there in a minute. The next step in your assessment process is now to evaluate behaviors. So remember all the little things I touched on? Do they know what to do? Who to call, how to call, that kind of stuff. So you want to make sure you evaluate how people are reacting in your facility. How do they react to stressors? How do they react to violent people? How do they react to escalating behaviors? And then what have you done to teach them how to react to escalating behaviors? And are they following it? There's some programs, and I could tell you all about all these different programs out there about de-escalation. No matter what it is that you're using, if you don't enforce it, if you don't engage using it, if you just say, here's the de-escalation training, it's 4 hours, go to it, have fun. Then you never talk about it again, and you never engage with that, and you never use what you learned, then what's the point? You just wasted 4 hours of time, times everybody that's been to that class. So you've got to gauge how people are escalating. And then the hello doctrine, let me tell you about that for a second. I implemented this in a health system about a year ago. And what the hello doctrine is, when I approach someone in a hospital, when I see someone in a hospital, I say hello. I don't say good morning. I don't say good afternoon. I don't say good evening. Why? Who is having a good morning, good afternoon, a good evening in a hospital? Anybody? A lot of people are not. Hello. Hi. You can get away with hi. Hi's a little upbeat, but that's okay. Hello. Hello. You also introduce yourself. How many of you slept in your own bed last night? Okay. If I came to your house last night at 2 in the morning, and I walked right into your house, and I walked right into your bedroom, and I turned on the lights, and I said, hello, what would you do? Some of you would shoot me, I know. I know. Let's transfer that to now you're in a hospital. You're in a hospital room that you're unfamiliar with, that's probably not got the most comfortable bed in the world, but we'll get past that. The door is usually open. There's people walking by that you don't know or have any control over. You're wearing an outfit where your butt's hanging out. You're not exactly secure in your environment, are you? And the staff just walk in. They just walk in looking down at the clipboard or looking down at their notes. They just walk right on in and go, okay, I'm going to change your IV now. You're going to touch me now. You didn't even introduce yourself. You didn't say hello. So what we implemented was this. I don't care who you are. I don't care what your role is. I don't care if you're a physician. I don't care if you're dietary. I don't care if you're EVS. When you walk into a patient's room, before you walk in, you do this. What am I doing? Before the knock.
Listen.
I want you to listen. I want you to listen to what's going on in that room. Take a 5-second pause. Sounds like they're having an argument. Sounds like I want to be cautious before I go in. Or I don't hear anything on but the TV. Okay. Then what do? Hi, I'm the nurse. May I come in? You're coming in anyway, but may I come in? What does that do? Say it again. You're asking. You're asking permission. How many decisions does a patient get to make when they're in a hospital? Very few. You're giving them permission to make a decision about something so simple as, may I come in? May I come in? Hi, I'm Mike. I'm with security. I'm just here to check on you and see how things are going. Introduce myself. Why I'm there. What is my purpose? What am I there to achieve? Why am I bothering you? So I had a hospital stay a little bit ago. It was overnight, and the nurse comes in, and she did it. She did the knock. She did the hello. I'm so sorry to disturb you. I know you were sleeping. Just stay rested. Stay asleep. I'm just going to check your bag, my IV bag. Okay. I'm fine with that, right? As opposed to someone just walking in, grabbing me, starting moving me around, changing things, and not telling me what's happening. Because when you wake me up, how many of you get startled when you get woken up? Yeah. It could result into a bad thing, right? You wake me up touching me, right? Depending upon who it is you're touching. By the way, do you know where not to touch? Wait, okay, let me rephrase that question. There are certain areas of the body you want to be cautious of touching when you initially walk into the room. One of those areas is the wrist. Another area is the ankle, because those are areas of control. If you touch my wrist, I may feel like you're grabbing my wrist and stopping my movement. Don't touch the wrist, don't touch the ankle. Then there are other areas, the neck, the head. You know, you want to introduce yourself, make sure they're cognizant of you being there before you go in and start to touch. This is all part of the hello doctrine. I know it's getting pretty complicated for just 2 words. But it's being aware of your surroundings and implementing a process that people follow that reduces the escalation of violence. And it's proven over and over again. The hello doctrine works. Try it. Try it for 6 months and see what happens in your hospital. Okay. Talk through, and I went all the way to the bottom, but talk through drills. How many of you pull drills in your hospital? Okay. Anything other than a fire drill? Anybody do an active shooter drill? Okay. Be cautious of your drills. Be cautious of how it impacts everybody else in that facility. If you do an active shooter drill, and bless his heart, we say that in the South and it means something terrible. This security director decided his hospital, he was going to pull an active shooter drill and he wasn't going to tell anybody, and he got his buddy who was law enforcement to put blanks in a gun and just go in and bang, bang. Not a good idea. He's not a security director anymore. Think of the fear that created. Think of the uncontrolled, unbridled fear that created. And what is the after effect of that fear, not only on your patients, but on your staff? Your staff will have PTSD for a long time because of that horrible decision. Now, let's spill that out into the community. Telegraph, telephone, telenurse, Instagram, Twitter, Facebook, social media. It's out of that hospital in seconds. And usually the first thing out is what? Shots fired. Not, we're having a drill today and it's going amazingly well and I'm learning a lot. No, it's shots fired at our hospital. So think about the impact that's going to have on your community and how it's going to impact your brand, the image of your hospital, your relationship with the local police department. So before you pull a drill, make sure you have all those circled and you're very aware of what that drill is going to impact. It's always good to do a talk through of a drill first, by the way. Sit down at a table with all the appropriate people and walk it through. And then decide, should we do that? All right, evaluate your responses. How are people responding to, we talked about this already, right? How people are responding to your, based off policy versus based off what they normally do. So in your assessment, you want to evaluate how people respond. But then here's a piece of this that we all miss, or a lot of us miss, is what happens after. Do we evaluate the response after the response? Did we do a good job? What were some areas we could improve upon? Where do we need training? Where do we need to change the policy? You need to have that talk through afterwards. And then you need to support your staff members. There was a shooting in Denver. It was called the Batman shooting. Do you guys remember that? It was in Aurora, and it was at the movie theater. So the shooting occurred in the movie theater, and one hospital took the brunt of the patients. It was University of Colorado Health. And it got to the point where, it started off shooting theater. Limited number of victims. We're going to bring a couple to you. That was the initial communication. Then there wasn't a lot of communication, because what happened on the scene was, before the ambulances got there, the police cars got there. And the police cars were putting victims in their cars and rushing them to the hospital. So you get one patrol car pull up, you get another patrol car pull up, and they just kept coming. And the emergency department, it was a good-sized emergency department, they ran out of staff. They couldn't meet the police cars anymore. So what did they have to do? They had one tech out there to kind of do an initial triage, and they had security officers coming out to help get the patients out of the cars and into the hospital. Now put that on a job description. Security, you're going to do security stuff and other stuff we're not going to tell you about until it happens. Think of the trauma when you're put into a situation that you've never experienced before, and now we got to think about the support. Now, a lot of us have EAP, right? Employee Assistance Programs. They started that EAP thing out there, and it was a phone call. Here's a phone number. If you feel upset, you call this number. They got 0 calls. So then HR decided we're going to bring them on campus, and we're going to hold some open meetings. They were flooded with people. People didn't want to make a phone call. That's impersonal. No. They want to be able to sit and look at you and talk to you. So think about what your support looks like. And on paper, from, another building or from the corporate office, it may look good to provide the phone number for people to call. But in reality, what's going to benefit the people that heal other people? What's going to benefit them? when they're trying to overcome the trauma that they just experienced. And then you need to look at what that staff support is and what that follow-up is when you're doing your assessment. And then the report, talked about this. What are we going to do with this report? What do we do with the reports? Do you write it, print it up, or store it, put it on your computer, label it 2025 security assessment, and that's where it stays? Or do you do something with it? When you do these reports, anytime there's recommendations, recommended actions from these reports, if you want to hide it, hide it. And honestly, if you want to hide it, don't ever do it to begin with, because it will bite you in the butt when an incident occurs and a lawyer does discovery, right? If you're going to do a report, let's do it right. Let's get the report. Let's put the findings together. Let's have our committee look at it. Let's look at what our findings are and what our recommended actions are. Then when you have recommended actions, what's the follow-up to the recommended actions? Well, back in February, we did that, and we looked at it, and we provided some recommendations. Okay, it's now, what month are we in? May? What have you done? What have been the results? So whatever committee it was in, keep talking about it. Keep looking at results. Keep looking at after the incident occurred or after you did the assessment, where are you? If one of your things was, we need to implement de-escalation training for the staff. Oh, good idea. Good idea. Let's do that. Put that in there. Have you done any? Have you engaged with anybody to create the de-escalation training to begin with? Have you implemented de-escalation training? If so, how are you doing it? I'm jaded and biased. I will just say that up front. If you tell me that you implemented de-escalation training and it was open for people to come if they wanted to come, it's not going to work. Who's going to go? Some people will go. Some people will go. But those are the people that care or probably were involved in an incident and they wanted something. But then here's what's going to happen. You're going to have a small minority of people attend your class. And then they're going to go out and try and implement it. And the rest of the staff are going to go, don't bring that horse crap in here. We're not doing that. Or they may not say anything, they just ignore it. They don't follow along with it. And it dies on the vine. So all that money, all that time you spent on figuring out what de-escalation training or what programs you're going to put into play, if it's just going to die on the vine, why waste your time? It's got to be supported. You've got to have your CEO in that classroom. And boy, that's a task, right? That's a feat. If it's not supported by administration, it's not supported. You've got to have nurse managers in that class. You've got to have nurse managers saying, this is what we're going to do. They run the hospital, right? And if they're not supporting it, it's not going to get done. You've got to be honest with yourself and with each other, and you have to say, this was the incident during our critique. What went right? Okay, everybody responded. Great. What didn't go so well, or what do we need to improve on? Well, none of you followed the de-escalation tactics that we were taught. Call it out. You have to. And that's what part of your assessment is going to show. So then you get your assessment, you put your report together, and we're in a circle. And there's nothing worse legally, there's nothing worse morally, there's nothing worse ethically, there's nothing worse for morale than pointing out a problem, making a suggested improvement, and then forgetting about it or never following through. Because all you're doing is reducing value and faith in anything else you do. Hey, we have a great de-escalation program. We noticed that was a problem. We noticed that was something everybody wanted. We're going to put this in place. It's not mandatory. You can go if you want to. You can use it if you want to. A year from now, when nobody's using it and your violence is the same or worse, how are they thinking of you now? What do they think of your style, your skill, your ability as leaders? So you're going to get a lot of, I don't want to go to training. But you're going to have to make it part of the culture. And the way you do that is you start off with training. You start off with the hello doctrine. And then I'm going to give you one more tool, one more little piece. I call it the what if. Every meeting, every huddle, every other huddle, whatever you want to put in play, whoever's running that meeting starts off with 2 minutes of what if. What would we do? We're all where we are right now. What would we do if we heard shots fired outside that door? What would we do? Anybody? What would we do? You ask the question. We're going to go to that door. Well, Lisa and I already know that door doesn't open. We're going to go to this door. Nope. That's our exit. If you do that enough, that 2-minute what if becomes a 20-second what if. Because now everybody's already thinking. Everybody's already thinking. How many of you have nurses or staff, any clinical staff or any staff at all, that work in multiple areas of your hospital? Okay, good. When you hire them, do you take them around to the multiple areas of the hospital and show them? This is here, this is how it's laid out, those are your emergency exits. When you're in this department, this is what we do. This is how, if something were to happen, this is what we do. There's nothing worse than going to a department in the middle of the night for an evening shift and you have no clue where the exits are, you don't know what you're supposed to do, you're not even thinking about it until there's a code, till there's an incident. Then you freeze. You get that adrenal dump and you just freeze. You don't do anything. And even if nothing happens to you, the fear that that creates is a lasting fear. And it will go into decisions about their employment later on, whether or not they want to stay with you or not. So think about how we're introducing people into different departments. How are we talking about this? How are we doing our program?
We glossed over, or might gloss over, a little bit about the recommendations. You know, I think anytime we have someone come in and conduct an assessment for us, we expect this report to be filled with recommendations. And if you're doing that for your organization, the expectation is going to be for you to put together recommendations. And it is extremely important that those recommendations come from either a regulatory compliance, situation. They come from leading practice. And where do you find that? Is that through the ENA, through ASHRM, through ASHE, through the American Hospital Association, wherever that is, NFPA. Very important that when you make that recommendation, because it's probably going to go all the way up to your board if it's financial. If you need new locks, or you want new cameras, or we need to hire a different landscape company, then it's going to go somewhere. And if they don't say, well, why do we need this? Just because somebody did this little thing, if it's not required, then we're not going to spend the money on that right now. Make sure that you are able to pull that up. There are 2 documents on SDAHO's website. One is that 100 and however many pages, and those areas have referenced those where you're going to pull that data. You can actually go to that, and it'll tell you this is the 10 things. Sometimes your accreditation association or the state may have some recommendations. So very important that you try to do that. But especially if you hire a consultant to come in, you better make sure that they're not saying, because I've got 30 years of experience, I've been doing this, you need to have these types of cameras. Make sure that they are able to pull a reputable law or a leading practice that makes sense, so that when it goes up there to the budget, somebody can say, okay, well, we really do need to weigh this. This is something that's very important. questions about that. I mean, I heard, for instance, you guys, I think, engaged Homeland Security to come and do one at least outside on your grounds. And inside, awesome. So they come, that's a credential, you know, that's from the Department of Homeland Security that came in. Make sure that those consultants, are they CEPTED certified? Are they certified as a healthcare administrator? What is their certification?
I think it's really important when you start looking at these that you really dig into what the requirements are. What are the standards? What are those things that CMS is telling you? How many of you know that CMS put out a directive that says you will not handcuff a patient? Right. You don't handcuff patients. Okay, that's great, but if you have handcuffs and you've never heard that before, what do you think your officers, what do you think security is going to do? They're going to handcuff a patient because they feel like they could handcuff a patient. You've got to make sure that whatever tools you're using, you have the right certifications and the right knowledge. So they were PATH certified. That's a certification in handcuffs, right? They were all PATH certified, but PATH certification doesn't talk anything about healthcare. So you got to know your stuff. You got to know what those requirements are from a healthcare perspective. Homeland Security is fantastic. You get them to come in, you get their recommendations, and their recommendations are going to be based off a lot of Homeland Security policies, right? Homeland Security has a whole section on healthcare if you go to the Homeland Security website. What they don't know is they don't always take into account that we have those annoying people called patients. And sometimes Homeland Security or a law police department, they don't know about things like, oh, I don't know, EMTALA, HIPAA. You know, those rare little bitty regulations that we sometimes have to follow if we feel like it. So you've got to make sure that everything they're telling you, you are the owner. And you're looking at that going, yeah, good. Ooh, this one might be an EMTALA problem. I'll give you an example. Had a hospital in Rome, Georgia. There's 3, so I can say that. Had a hospital in Rome, Georgia. They hired off-duty police officers because they had an emergency department and they wanted the nurses to feel safe, so they put off-duty police officers in the emergency department. Do you know where they put them? They put them at the front entrance to the emergency department. They were cited for an EMTALA violation. Do you know why? Can you guess why? 2 people complained and said that they were fearful that they would be arrested if they came into that hospital. Now, it was justified because that police officer was running just about everybody that came into that hospital. And he actually arrested 2 people that had open warrants. Try getting out of that EMTALA violation. So, good idea, off-duty police, good idea. You've got to make sure you understand what you're doing with them, how they're engaging, and that they understand the rules as well. Right? Same thing with a camera, same thing with security officers, same thing with anything you deploy. You got to make sure you understand the purpose and the impact of what could happen. So all of these are fantastic, right? But it's up to you to blend them into your culture and into your environment to make sure that it follows through with what we're doing. Okay, you guys have been super quiet. I promise you it's not going to be quiet later on. Any questions, comments? They're looking at their watches. That's a bad sign. Yes, sir.
Maybe back to the handcuffing question. The dilemma that we ran into is, one, you have CMS standards where handcuffing are deemed a restraint for CMS. And the flip side is you have OSHA, which says that you have to have a safe environment. And the 2 federal agencies actually do not speak well when it comes to that.
No, they don't. No, they don't. So here's the compromise that I came up with, and I had this battle with a CMS surveyor, and they actually like, okay, it makes sense. Before you handcuff someone, what is the purpose of handcuffing someone? No. You're restraining a criminal act. You've got to make sure the criminal act is there, right? If someone is acting out, they're not, could you come in here and do something? This patient will not take their medication. I'll handcuff them. No, that's not quite right. This patient came in and they're violent and they're swinging at me. Is that a criminal act? Yes, it is. Did you handcuff them for the criminal act? Yes. Did you notify police? That's the piece you have to do. If you handcuff someone for a criminal act, you have to notify the police. The police will respond. I don't care what the police do. If they arrest them, they arrest them. If they don't, they don't. I don't care. But my butt is covered for CMS. Do you want me to rephrase that? Sorry. I'm covered from CMS. So now when we use handcuffs, there's an asterisk. Handcuffs are not a clinical restraint. They're not in our clinical restraint policy. They are used only and solely for the purpose of criminal acts. Once they commit a criminal act, they are now a criminal. And if we have to handcuff them, we will call the police and the police will respond. And we file a police report. But I want you to understand one thing. I'm a patient, I'm your patient. I'm acting out. I'm acting out to the point where you handcuff me and you call the police. The police respond and they say, yeah, we're not arresting them. Where are they going? Whose are they still? They're still in your ED. They're still in your hospital. And now, have you helped the matter or have you worsened the situation? It's going to depend on the situation, right? Every situation is a little bit different. But you need to think about handcuffs as one of your last resorts. You need to use all the de-escalation tools in your tool belt before those handcuffs come out.
And intervention, other interventions. There's some wonderful interventions because it does escalate to the point of physical intervention. And as long as everybody's training together and it's clinically led, it could be someone from facilities, it could be someone from environmental services, if you have security, it's a team effort and you're responding, but the intervention is clinical. So making sure that you do have an answer, because you're exactly right, it's unsafe. When someone's fighting, even if they don't know what they're doing, they can cause a lot of injury and damage. So you've got to think ahead of that. I mean, I feel you. I mean, I remember back before that CMS forbade that. Sometimes all we had were handcuffs. It was not appropriate, but we have evolved. We know now that there are other types of interventions. So great response and great follow-up question on that. And I know that we're getting a little bit closer to the lunch time, and we wanted to talk about, we're going to show either the video, which is about 20 minutes now, or we're going to show it while you're eating. But before we do that, we also want to maybe have 3 drawings. We do have some giveaways. We have a book that Mike wrote, so that'll be one. We have some challenge coins. I think I have 5 challenge coins, and if you're one of those individuals that like to collect those, I am. And then I also, and I have to walk in front of this again, we have a book here from one of our colleagues. Some of you, how many of you were here last year when we did some training? Some of you may then remember that I talk a lot about left of bang. Who knows what left of bang is? Go ahead, shout it out. What's left of bang? This is a book that was written by a couple military guys. And they wrote it so that people like us, civilians, could actually apply that. It's some military strategy, but that we could apply it in our everyday lives. And left of bang, bang is that event that happens out there. It could be a patient elopement. It could be that bad patient elopement where they run out into the street and get hit by a vehicle. Left means what are you doing to kind of think about proactively preventing bang from occurring? What are some things, kind of like what Mike said earlier, what if? You're thinking left of bang if you're talking about what if. If you're ever right of bang, there's some things we're humans, we can't think of everything. So what are you doing once an event occurs to get back left of bang? So anyway, one of our colleagues wrote this book. It's called Living and Leading Left of Bang. And I think that this individual may actually be doing some training at some point with SDAHO.
Emily had been on edge for weeks. Her estranged husband, Brian, had become increasingly aggressive after she filed for divorce. She had a restraining order, but she knew that wouldn't stop him if he was determined. At 6 p.m. on Tuesday evening, Brian entered the hospital, but not through the main entrance. A back door had been propped open by a staff member for just a few minutes while he took a break outside. No cameras covered the area, and no one noticed when Brian slipped inside. He walked through the back corridors unnoticed, blending in with visitors. The hospital had no way of tracking him. No ID checks, no visitor passes required. Within minutes, he was standing face to face with Emily.
This scenario, along with many like it, occur more often than not. Unfortunately, injuries to healthcare workers due to violence have become a common occurrence. It is undisputed that people who work in environments of increased fear and anxiety have divided attention and focus less on their jobs. When that job is healthcare, there is an increase in undesirable patient outcomes. When looking to evaluate security, you must look at it from two directions: reality and perceptions. And your solutions must be actionable items that become habits.
The goal of a security risk assessment for a healthcare organization is to identify, evaluate, and mitigate potential security threats that could compromise the safety of patients, staff, visitors, and assets. In short, the goal is to provide a safer environment for all. As a part of the review process, we recommend that you apply these 4 principles. First, natural surveillance, and that will help deter criminal activity by increasing visibility. Natural access control, clearly distinguishing your public versus your private spaces. Territorial reinforcement, creating an environment that defines private areas and fosters a sense of ownership. And 4, maintenance, ensuring that you upkeep to discourage vandalism and other crimes. Your recommendations should be grounded in these principles, focusing on modifying the existing environment to influence human behavior, either as an alternative to or in conjunction with technology to minimize operational and maintenance costs. Areas that are determined to need heightened security should be based on the results of your security risk assessment, to include the type and criticality of activity that occurs in the area, the patient volume, your staffing levels, your incident trends, workers' compensation reports and injuries, your community demographics, and even your criminal activity over the past 12 months. The most critical heightened security areas can be designated as security sensitive if access is controlled to and from the area. To effectively evaluate security initiatives in heightened security areas of a healthcare facility, the Threat Assessment and Management Program should be developed. It should be data-driven and evidence-based. There are 5 key steps to developing a Threat Assessment and Management Program. The first one is establish your multidisciplinary threat assessment team, your TAT. Make sure that team is trained in threat assessment models, non-escalation, de-escalation techniques, and emergency response planning. Number 2, conduct a data-driven risk analysis and basically gather your incident data from reports. Has there been unauthorized access, theft, patient elopement? Your workplace violence reports. Have there been assaults or conflicts with visitors? Patient behavioral records. What type of patients do you have? Forensic, psychiatric units. Emergency event history. Has there been a lockdown, an active assailant threat? How does the staff perceive their safety? use predictive analytics to identify your trends. Number 3, develop immediate response and intervention actions for those high-risk situations. 4, consider additional measures in those heightened risk areas. That might be enhancing your access control, improving surveillance monitoring, implement staff training and awareness programs. And number 5, develop an ongoing, long-term strategy that is sustainable. You've got to proactively surveil the program and then collaborate with external agencies, law enforcement, mental health professionals on a case-by-case situation. Some heightened risk areas that may be included: your pharmacy or your medication storage areas, health information management, your executive offices and suites, human resources, the physical plant. You may also want to consider the services that you provide and the special patient populations they bring in. Emergency department and critical care areas, labor and delivery and pediatrics, behavioral health, if you have specialized clinics such as pain, substance abuse, dialysis, hospice and end-of-life care, and other services that bring in patients who may have those high levels of anxiety and fear.
During your assessment, review your policies, processes, and protocols to ensure they align with industry standards, guidelines, and best practices. For example, look at your hiring process. Do you include background checks? Granting access levels. Consider who you're granting access levels to and what levels you're granting. Reporting, investigating, analyzing, trending, and preventing incidents. Response protocols. Develop your response protocols to ensure people understand what those protocols are and when to implement them. Training. Non-escalation, de-escalation, response, and most importantly, follow-ups. And then terminations. How do you handle the terminations of employees, whether you do them on campus, off campus, in offices, or in conference rooms?
The ED chart read, severe back pain, requests dilaudid, allergic to everything else. Stepping into the room, Dr. Carter found a man in his mid-40s sprawled on the stretcher, shifting uncomfortably. His ID read James P., and Dr. Carter had a feeling he'd been here under different name variations before.
Doc, it's bad. I need the Dilaudid. It's the only thing that works. I'm allergic to everything else. Morphine, Toradol, even Tylenol. I swear, I can't take them.
That's a lot of allergies, James. Have you tried any other treatments before coming in today?
Of course I have, but nothing works. Just give me the shot so I can go home.
James, I've checked your records. You've been in here 4 times this month for the same complaint. We've given you non-narcotic options, and you've refused them every time.
I knew it. You guys think I'm some kind of drug seeker. But I'm in pain, lady. You don't know what it's like.
I do understand pain, and I know how hard it is to live with, but giving you Dilaudid is not the best medical choice here.
This is ridiculous. You don't even care about your patients. Forget this place. You guys are useless.
Applying safety protocols in the emergency department is critical to protecting both healthcare staff and patients. The ED is a high-stress environment where emotions run high, and situations can quickly escalate, leading to potential violence, verbal aggression, or unsafe conditions. Some of these protocols include situational awareness, staying alert to potential risks, your safety stance, your position for protection. Stand at an angle with an open stance rather than directly in front of an agitated patient. Maintain a safe distance with the ability to quickly step away if necessary. Treat all persons with respect and dignity. This diffuses hostility through professionalism. Implement de-escalation tactics, reducing tension before it even escalates. Know when to call for help. Maintain a clear exit and clear exit routes and having an escape plan. Communicate clearly with team members with a positive intent. Develop a security management plan based on identified risks associated with the emergency department, including trauma level designation, patient volume, types of cases treated, incident trends, community demographics, and criminal activity over the past 12 months. Consideration should be given to completing the following reviews and actions in the emergency department. Evaluate the need and implementation of a weapons screening process before patients and visitors enter the waiting area. The emergency department waiting area should be physically separated from the treatment area and designed as a self-contained space. Seating and furnishings should be securely fixed, fastened, or otherwise designed to prevent their use as potential weapons. Access controls should be placed to regulate and limit entry into both the emergency department treatment area and the main hospital. An appropriately equipped room or an area within the emergency department should be available for treating behavioral or mental health patients, as well as other high-risk individuals. The ambulance entrance should be secured and separated from the walk-in entrance and waiting area. Security equipment and technology should be in place to minimize risk to staff and patients, including electronic access control, video surveillance, and duress alarms. Additionally, the emergency department should have the capability to be quickly locked down in case of an emergency requiring restricted access to protect patients, staff, and visitors. Physical security measures and procedures should be implemented to prevent the unauthorized departure or elopement of patients who may pose a danger to themselves or others. Emergency department staff and security staff should receive ongoing training in workplace violence prevention and management of aggressive or violent patients. Policies, procedures, and training programs should be established for security personnel regarding their role in managing high-risk patients. The journey to the hospital doesn't start at your front door. It starts out there where they begin their journey, and it moves onto your campus. Your campus should have a clean appearance and an appearance of presence. Use clear signage and direction, easy wayfinding, pictures and colors with minimal wording because people in crisis don't read signs. Easy to remember parking areas and have clear lines of sight in your parking areas.
Let's begin with the physical exterior environment. As we move from the furthermost point of the property to the facility buildings, there are access points that should be considered. Your entrances. How are people greeted? How do you know who is in your hospital? Why should you care? It is important to identify and appropriately control the entrances into the facility. It is recommended that public access entrances be staffed when the doors are open so that patients and visitors are personally acknowledged, welcomed, identified, and given appropriate direction. Additionally, this process provides a deterrent for individuals who are not supposed to be in the area. Your exits. Locking mechanisms on all exits should be audited on a regular basis. These audits should include: are the doors physically locking? Can someone bypass that latch mechanism? Has the mechanism been intentionally compromised? Are all life safety codes being followed? Hospital loading docks and delivery areas pose a safety and security risk due to their ease of access, also their proximity to internal and external areas, risks of injuries, and potential for unauthorized entry. It can compromise patient safety, medical supplies, and overall facility security. Vehicular access control to and from this area is as important as pedestrian access. Access control in this area is complicated as the garbage needs to exit the hospital while food, medication, supplies, and equipment must enter the hospital from the same area. Proactive oversight, access control, video surveillance, and a vendor management system in this area is recommended to reduce the risk of injury, unauthorized access, and theft. Landscaping and clear line of sight. Natural surveillance. Apply the 2-foot, 6-foot rule. Shrubs should be maintained to be no higher than 2 feet in height. Tree canopies should be 6 feet or higher. Properly maintained landscaping such as trimmed hedges, low shrubs, strategic placement of trees ensures clear sight lines to entrances, walkways, and parking lots. This discourages criminal activity by reducing hiding spots. Access control. Well-placed vegetation can serve as a natural barrier to direct pedestrian flow and restrict unauthorized access to sensitive areas. Territorial reinforcement. Landscaping elements such as decorative fencing, flower beds, and pavement treatments help establish clear property boundaries, reinforcing the perception of controlled and monitored spaces. Lighting integration. Landscaping should complement the exterior lighting to ensure that there are no blind spots or shadowed areas at night. Parking areas. Parking lots should be designed with open sight lines from the building and streets, allowing security personnel, staff, and visitors to observe activity. Controlled entry points, fencing, and designated pedestrian pathways reduce opportunities for unauthorized access. Adequate and well-distributed lighting across parking areas minimizes dark spots, ensuring safety for employees and visitors at all hours. Blue light emergency phones or call stations could be strategically placed and well lit to provide immediate access to assistance. Parking areas should have visible and well-lit signage to direct visitors, reducing confusion and ensuring people can find safe and appropriate entrances. Bright and uniform lighting on walkways, entrances, and parking lots deters criminal behavior and enhances visibility. Motion-activated and timed lighting provide energy efficiency while ensuring areas remain illuminated when needed. Lighting should be strategically placed to eliminate dark spots and avoid glare that could impair visibility. Adequate lighting ensures that security cameras have a clear and usable video feed for monitoring and crime prevention. Clear, concise, and visible signage. Signs should be easy to read, well-lit, and strategically placed to help patients, staff, and visitors navigate efficiently. Wayfinding signs should be positioned at key decision points such as parking entrances, pedestrian walkways, and facility entryways. Signs should include emergency exit directions, security hotline information, and restricted area warnings to promote safety.
When you think about the tools that you're going to use in your security program, you need to consider what the purpose and the goal of each tool will be. Technology can support you. A hospital security technology program should be integrated, proactive, and scalable to adapt to evolving threats. A layered security approach using a combination of physical, electronic, and AI-driven systems facilitate comprehensive protection in the healthcare environment. Technology to consider. Access control systems, which may include visitor management systems, as well as two-factor authentication for high-risk areas, such as the pharmacy. Video surveillance and monitoring. Intrusion detection and alarm systems to include duress and panic alarms. Emergency communication and mass notification systems. Perimeter and parking security. Smart lighting and motion-activated lights enhances safety in parking lots and secluded areas. Begin by developing a video surveillance philosophy for the organization and use this document when designing new camera systems or expanding on existing systems. Make sure every camera has a purpose and expected field of view. In general, the coverage goals for surveillance cameras is to detect activity, observe movement, recognize and identify individuals in the following areas: exterior cameras, interior non-clinical, pharmacy, emergency department, interior clinical.
Alyssa had cared for hundreds of patients, but none had been as difficult as Mr. Donovan. His condition was critical, and despite the team's best efforts, he passed away in the ICU late one evening. When notified, his son Jake was furious. At 10:42 p.m., Jake entered the hospital through secured sliding glass doors at the main entrance by pulling them apart with his hands. He slipped inside unnoticed. He walked through the dimly lit corridors and stepped onto the ICU floor. He knew exactly who to blame. Alyssa was leaving the decedent's room when she heard, "You let my father die." Before she could react, Jake lunged and pushed Alyssa back into the room and closed the door. There was no one nearby. Hospital staffing was lower at night, and no one had foreseen this kind of risk. Workplace violence has become a growing concern in the healthcare industry. According to OSHA, workplace violence includes any act of physical violence, harassment, intimidation, or other threatening behavior that occurs at the workplace. To prevent such incidents from occurring, it is important to establish a comprehensive workplace violence prevention program and provide adequate training to employees. Consider these important steps as your facility develops a workplace violence prevention program. Step 1. Agree as an organization on the definition of workplace violence and what it includes. Seek out reputable definitions to assist with this. OSHA, the Joint Commission, NFPA, ANA, AHA, IAHSS, and others. Step 2, establish a culture of safety, starting with a reporting system that is easily accessible to staff. Step 3, build a team to assist in creating policies and procedures. Step 4, deploy hospital-wide training and resources, and this includes all staff. Additional tools and policy templates may be found at SDAHO.org.
Resources are available online, which include an assessment template where you may document the findings at your facility, as well as a sample report for recommendations developed from your findings.
What I'm going to just kind of talk a little bit about is why the traditional, what the problems are with it. Number one, what is violence in workplace? You saw on the video kind of the definition. We want to make sure we know what we're talking about, what the problems are, and how do you go beyond that traditional script that we're teaching our employees to use, or those things that we say when we think we know how to de-escalate behavior. And then what is each of your roles as a leader in your organization for changing that safety culture? Obviously, we can't change who's coming in our doors, but we can have an impact of what's going on in our facilities. So you need to make sure you've got a really good definition. This one is from the American Hospital Association, so it's much closer to our own environment. Talking about verbal, nonverbal, written, or physical aggression, threatening, intimidating, harassing, humiliating words or actions, bullying, sabotage, sexual harassments, physical assaults, or other behaviors of concern involving staff, licensed practitioners, patients, or visitors. So very specific, that one. And again, that's something that you need to look at. Also, understand what a threat is. We see that as part of workplace violence, but make sure that you know what a threat is and you have that somewhere in your policy or your definition. We know, according to the American Nurses Association, there's 5 types of workplace violence. We talked about the first one, that criminal intent, someone who's coming onto our campus to actually commit a crime, maybe steal something or do something. And then there's that patient-generated, between the patient or the client. We talk about that a lot. We train a lot on that one. Worker on worker, or what I use the term is lateral violence. Personal relationships. You saw one of those in the video, that very first one, that the young lady had actually had filed a restraining order, but he came in anyway. And then the ideological violence. We saw an uptick in that the last few years. It may be political, it may be just because you do animal testing, who knows what it is, but those are on some various campuses as well. The top 2, obviously we know it's that patient-generated, that's number 1. And that doesn't mean that we have criminals as patients. We know, those of us that have worked in the business for a long time, that because of the situation, there's going to be acting out behavior when sometimes those individuals would never even do that based on their condition. And then the second one is the lateral, the worker on worker. Anytime you get a group of humans together, there's going to be friction. So those are the 2 that we really need to be more concerned with in healthcare.
Hey, Lisa, can I just interject?
Absolutely.
Just as an asterisk here, make sure that whoever your accrediting organization is, make sure you check their standards. They may have their own definition of workplace violence that they want you to follow. Joint Commission does, DMV does, CMS does. So make sure you follow whatever your accrediting organization says And when it comes to tracking, check your accrediting organization, but also check your states. And stay current on state law, because more and more states are starting to require hospitals to report to the state what's occurring as far as workplace violence, and it breaks them down into the types. California has more types than anybody else, go figure, but every state is starting to get on board with, you know, that reporting back to the state. So these are great, but make sure you check with your accrediting organization and state requirements.
Thank you, Mike. Those of you that were here with the ring, where you see that the threats and lateral violence, if left alone, turns into physical violence. And there's studies that are out there. So make sure that you kind of put that in the top of mind as you're putting your programs together. So why prevention and de-escalation of violence matters, you know, I think Mike went over that a lot this morning. We know that we've got there's more violence and more injuries in healthcare and social services than any other occupation in the U.S. It impacts our safety, retention, morale, and whether the patients are getting the quality care that they need. And then, obviously, as Mike just alluded to, your accreditation agencies, regulatory agencies, they require us to take certain actions. So it's very important that we have something in place that is valuable, that can de-escalate, hopefully mitigate and prevent, but also de-escalate violence, and we are training on it on a regular basis. Of course, I just kind of put this up here, just kind of giving you some more data. We're 5 times more likely to be injured. ED and psychiatric have, you know, the highest rates. And as Mike mentioned this morning, underreporting. People just feel like nothing's going to come of it, so I'm not going to report it. It's just part of my job. And you'd think that we would be over that by now, but it takes more energy. You know, security is not easy. It's complicated. So what is the problem that I'm talking about with the regular de-escalation training? So some of you mentioned MOAB. I've been a MOAB instructor. You mentioned CPI. I've been a CPI instructor. And both of those are very much out-of-the-box training. And I'm not saying they're bad. I just, you know, you have a very prescriptive syllabus that you follow. So the only negative that I have is they theorize that one size fits all. So sometimes that can be an issue. Sometimes it fails to prepare us. I know over the years, I got complaints from my staff telling me that, you know, if we use this, we're going to be, you know, hit, we're going to be hurt. So we stopped using that. Sometimes they assume that the skills are going to be mastered in one class, in one session. You know, we finally get to be able to bring somebody in for 4 hours or 2 hours, 8 hours if we're lucky, but you and I both know, if you've been an instructor, that those skills are not mastered unless someone is exceptional. And sometimes these trainings forget those moments where there may be a visitation dispute. We have some aggressive family members, and there, as you saw on the video, pain med demands. There's plenty of others, but they don't always go over these little situations that occur in our environment. So what I've also seen is it's not always adaptable, because the companies, if you are, whether it's your own, which that in itself is important, that you've put that through the paces, so that if you've grown your own, you need to make sure that your learning, your clinical education, your education department has put that they absolutely agree that they would back this. If someone uses this, you know, that in itself has been, there's evidence-based information out there, that everybody's trained in it, and they would back that. So with companies, if you go outside of what they've told you, then guess what? They're not going to back you. It's very specific, and you've got to stay within those parameters. So it's not very adaptable. And as everybody has said, talking either to Mike and myself or just among themselves, who has the time? You really don't get to practice it. It's just kind of a one and done, and if it's every 3 years, if it's as soon as you're hired, and then that's it, then that's obviously that's not going to help if you don't use it and train on it. And the focus is always on being able to control the individual that you're dealing with, that patient or whoever that is. And very little of it is on preparing you, the individual that's actually taking the action, on how you prepare yourself. How do you need to prepare yourself mentally and physically? So again, they don't have skill reinforcement, and most of the time if you can do it or you're in the ballpark, you're pretty much, you get that check. And most of us are looking for that check. Just like we do our annual training, whether it's LMS or whatever it is, we've got to get it done. I want to get a paycheck. So we really don't look at the skill. We know that skills degrade over time. Mike mentioned this morning that he had one group, they actually go to the range once a year. Once a year, and once a year is not enough for anything. And if you think of deadly force, having that fatal deadly force, those skills degrade if you aren't training on it or going for that at least once a month, once every 2 months. And then what works in one setting may fail in another. This works in the ER. This is how we handle it in the ER. But when you get up to ICU or vice versa, let's say what works in ICU with those patients definitely will not work in the emergency department on a Saturday night with a full moon. So how do you go beyond the traditional script? Again, we know that the theories crumble if we're not able to adapt the training to our specific situation, our organization, the culture, and the individuals that we're serving. A scripted phrase fails a clinician during a volatile ED incident. For instance, you saw the situation with the drug seeker. Any of you have drug seekers in your ERs? And they've always got a story, and sometimes the failure is not just the patient, AMA, as that guy did, but it's there's engagement. There's some sort of physical confrontation. So what could we do better? How could we really engage with those individuals? So what I feel like is training needs to be moving to next steps, really talking about our tone. Mike talked about that hello doctrine and that calm demeanor. And, something that I'll mention in just a moment is we don't know what each of us are going through. We certainly don't know what the patients are going through, but my coworker may have lost a loved one or may be having an argument with a spouse. We don't know what's going on in somebody else's life, and we assume that everybody's going to react in the same way. Make sure that we validate emotions. Don't just be logical. Logic doesn't work in our environment, rarely. I mean, it does if you're getting a dose of this or a dose of that most of the time. But make sure that you silence, pause, redirection. One of the things that we look for is, I think, the rule of 24, being able to respond versus react. When something occurs, if you can, wait 24 seconds before you respond. Now that's a long time, but what it does is it gives you enough time, hopefully, to have listened and try to remember what it is that you want to say to that individual. If you do not, for instance, if it's a coworker, you do not have to respond immediately. Wait 24 hours. Maybe it's an email that really just set you off. Wait 24 hours and really calm down and think about it. And if you absolutely have to respond, figure out a way that you take a pause. So something that and I know if you're going through MOAB and CPI and some of the others that you guys mentioned, we really talk about how our demeanor and the words that we say, how that's so very important. I think here it's really important. At the middle one, I think you look at Harrison Ford has that resting hateful face. He can either be happy or he can be mad, but it's the same face. And you know, as we get older, I think sometimes I probably have a resting hateful face because, you know, gravity takes hold. We need to remember that. What is it? What do we look like when we enter the room or when we're talking with someone? And I love this one with, you know, honey, I want you to, if you go to the supermarket and get 1 bottle of milk, and if they have it, if they have bananas, bring 6. So he comes back and he got 6 bottles of milk. And she was just furious because he thought, you know, to him, he heard her say, if they have, you know, the bananas, get 6 bottles of milk. So how we say things, people comprehend those differently. And then how many of you use emojis on a daily basis? I absolutely do. You know, it's been 4,000 years and we're kind of back to those hieroglyphics. Be really aware of that with your coworkers. You know, very important. So these are just some principles. You know, I don't want to absolutely go over each of these, but use your silence strategically. Don't just, if you're silent, then you're upset. Make sure that you're listening, and maybe the question is, what's the most important thing that I could do for you right now? You know, give them a chance to give you some feedback, and then redirect it. For instance, you know, don't become defensive. It's very easy to do. I really have to check myself on that. A visitor in the ICU could be redirected to some sort of resolution. And I think I use the ICU a lot because you don't always think about the visitor responses, but really those are where we end up with a lot of issues in the ICUs. And then maybe combine humor with your humanity. I've done this many times. For instance, a manager could share a self-deprecating story that ends with humor and empathy. If you're having that conversation, there's nothing wrong with being humble. You know, a little self-deprecating humor can absolutely change things up. And then when you're being able to move from de-escalation, we train on de-escalation, but how do we resolve the situation? Be able to figure out a way that we are going to resolve this. For instance, an ER nurse finds a way to follow up with ongoing updates. You know, I will be back here every 30 minutes, ma'am. If you'll have a seat out here, you've got my word. Every 30 minutes. If I can't come, I'll send someone and we'll update you on your father or your son. So really find a way, okay, they're calm now. What are we going to do to maintain that calmness and really get to the bottom of it? So again, use those dynamic role plays. You know, we're going to do a little bit of that in a few minutes, but checklists are great. You saw a lot of those this morning, but kind of look at some of the things that really do happen in our facilities. And also get them to change mid-scenario. You know, our mind goes, okay, we'll do this and this and this. Well, all of a sudden, it's redirected. It's changing it up. What do you do then? It's kind of that what if. Here this situation is, what if there's a secondary person that comes in with a firearm? You know, change it up and really be thinking about all of those. Shift the approach based on the person and the context. And I'm sure that there's plenty of clinicians in here that would say the same thing about security. But in security, we had a couple of nurses that worked perhaps in the emergency department. When we knew they were on duty, we knew we would be fighting because that was just their personality. And I'll be honest, I knew the same thing about some of my officers. If they were on duty, I knew I was going to get a call if I wasn't already at the hospital. So it's important that we think about these wonderful staff members that do a great job, but maybe they're not great when they have to interact. So how do we train to that? And practice staying calm under escalating circumstances. You know, we really kind of, the adrenaline gets up there, and as you know, 10 seconds can seem like 10 minutes, especially if you're trying to restrain someone or trying to calm them down. So the power of the nonverbals, which I know those of you that train, we talk about proxemics, but that open posture, the eye contact, as Mike talked about this morning, your stance awareness, be open but be safe. You know, you talked about how we trained on that at our last one with the stop sign and make sure that you're not too close to those individuals. The power stance. We do that a lot, those arms crossed. You know, we call the team in because this person's become threatening. And some of the team comes and, you know, they're there. It's like, yeah, you try me. So they come in with a power stance instead of maybe not even showing themselves. For instance, the nurse diffuses the tension with body language. You know, making sure, how can you be viewed as empathetic? Maybe the person really does want to calm down and this person's made them mad. Have somebody else come in that's empathetic. You know, let them, it's okay for you to back away because they may be ready to cooperate with somebody. Maybe they just can't lose face and cooperate with you. Make sure that your tone is with that empathetic language. I have actually, especially in the emergency department, I've had a recent stay in the hospital as well. I had a respiratory situation, and I can't tell you how wonderful it was. I was not expecting it, but it was everybody's tone, their engagement, and I couldn't breathe very well, but it was wonderful. I wanted to cooperate. And some of the things that, you know, again, I keep talking about Mike when he was really talking about the training, go down to even a whisper. If they're shouting, you know, you can say, I understand, yes, sir. What is it that I can do for you right now that would help you? Yes, sir. Maybe even get all the way to a whisper. It's amazing how just a few of those things calm the situation. Again. So, as leaders in your organization, what is your role in changing that safety culture? So you should be the ones, we should be the ones modeling that non-escalation behavior. We've got to be the ones that show the humility and really model the behavior that we want to see around us. We've got to be accessible. If it means going to the patients, whatever it is that we've got to do. And for critical access, that's a given. We all do everything. Recognize and reward when there's a successful conflict resolution. I mean, make that. When you're giving out the awards, it was great. This guy came in and we just knew because he was inebriated, it was going to be, and so just went in there, had a great conversation, and really make sure that you reward that. And then, as I mentioned a moment ago about being trauma responsive, and if you look at the graphic here, you see the taller dog said, how deep is the mud? And the shorter one said, depends on who you ask, because the shorter one almost has it up to his neck. You know, he thinks, it's not bad, but the little one almost drowned in the mud. So I think it's important that you understand we're not all going through things the same way. We all have different experiences that we carry with us. There's things that we can say and do that's going to take somebody back there. So it's important that we kind of remember that as leaders. Now, we can create safer environments that employ those trauma-informed responses. You know, I know we talk about trauma-informed care, but being able to be trauma-responsive. And it acknowledges, again, that we're all different. So even just coming in with the bright lights, the noise, the emergency department, the hospital in general, could absolutely trigger some of those things. And making sure that we're more supportive, the environment is more supportive. This, to me, if you don't take anything else from these slides, we are all responsible, especially all of us leaders, for the energy we bring into the room. The situation is either going to become physically and emotionally safer with our entrance, or it's going to be less physically and emotionally safe. And just kind of remember that. We're responsible for that energy, every single one of us. So everything that we do has an impact. And how does your presence influence this? Does it break the tension? You know, I know at times I've escalated over the years because I come in and, you know, I've run down there, I'm going to solve the situation. And I've escalated it, not intentionally, but just Lisa coming to the rescue. And that was totally wrong on my behalf. You know, make sure that it's mind over matter. Regulate your own energy first. like your body language, your tone. It's like taking those 24 seconds, if at all possible, before you enter the situation. Make sure you're breathing, get your mind cleared of whatever's going on at work, at home, wherever. And then it starts with your own self-awareness. You know, we can teach it all the time, but if we're not aware of ourselves, then we can forget it. A clinical leader calms a shouting patient by validating. Absolutely. Let me see what I can get you. Let me check your chart. I'm going to bring you some juice and crackers. And I want you to just calm down. I'm going to bring it to you. Make sure that there's, we can all do extra things if we think, outside of the typical routine that we're all doing. And again, energy is contagious. It impacts everybody that's involved. Enter with confidence, not chaos, which means stopping at the door, think about it. Don't come in like Lisa, I'm going to solve the world hunger right now, but really come in with confidence and understanding and empathy. Mike talked a little bit about situational awareness. I'm bringing it up again. This is the Cooper's Code. It's very important that if you've not seen that, you can download it. It talks about the white is basically we're on our phones. We're totally oblivious of what's going on around us, and I think probably most of us in this room can say that we're probably in the white zone at times, which is really bad. The yellow is where you're relaxed, but you're alert, and that's kind of where we all want to be. Your orange is when you know something doesn't look right, so you're ready to respond. And of course, red is when you're in the heat of the situation. So really understanding how to remain in that yellow. Simulate that when you're doing your training, you're conducting the training. And remember that the standard scripts fail without having cultural understanding. Who out there, what are the various cultures that you're serving in your community? Make sure that we take an extra step to understand that so that we can absolutely relate to those cultures and not make anyone feel that they shouldn't be there, that they are excluded. Train for those diverse populations and emotional responses. I don't know exactly what some of your communities, what the diverse populations are, but we had some that did not want a male physician, a male nurse, to be in there with their spouse. Everybody had to be female. And we had to acknowledge as much as we possibly could when we could meet that. And if we couldn't meet that, we had to really train on those scenarios. If we can't bring in so-and-so, if we don't have a practitioner that can come in, what are we going to do to de-escalate and still serve that patient? Again, language barriers. If you don't speak their language, what are we doing? And I mean, for critical access, I'm sure you're lucky if you've always got someone that is bilingual and on duty at any given time, regardless of what that other language is. I mean, do some of you have bilingual 24 hours a day? Very few. I mean, that's really the way it is in most hospitals. I'm almost finished here, but what's really important with your training, and part of this is when we talked about the assessment this morning, it's layers, being able to make sure that your training is coupled with those layers of security. It could be, some hospitals have K-9 or security officers. What kind of threat intelligence do you have that's going on in your community? Do you have metal detectors? Do any of you have any kind of metal detectors in the ER or anywhere? Okay. Access control, lockdown, if you have to lock everything at once. Do you have panic or duress systems? What kind of cameras do you have, and are they smart? Do they have some analytics so that they could look for certain things if you put that in there? And you've got to have someone on staff that understands how to work with that. And then your mass communication. Also, the layered training, your layered controls should also go with your administrative layers, those policies, procedures, your incident reports, a threat management team, security which may be, again, your facilities, some of the other folks in the department, should be training with your clinicians, because that's the people that are going to respond. Everybody should understand what's going on and defer to that clinically led intervention. It's very important that it's clinically led. If you've got BERT teams, and then of course your Workplace Violence Committee. So summary, I think your training, based on what I'm seeing out there, the leading practices and my own experience, have some realistic scenarios, reflections, nonverbals, provide refreshers and leadership involvement. If your executives are not getting in the training, that is a mistake. They really need to see what's going on and how you're training. Incorporate emotional control amid chaos. Adapt the training based on your regular security vulnerability assessments. What did you find? What were the recommendations in the last assessment that you did? How do you incorporate that into your de-escalation training? And practice ongoing situational awareness. What are some of the things that you've heard about? Just like the 3 scenarios that we talked about there. Think about those scenarios. I'm sure that all of you've had something. Maybe it didn't occur the way these did, but you've had something that happened. Incorporate those things into your training. And promote that culture of safety. That's probably the biggest thing that you can do as a leader. Again, implementing your layered controls. So let's see. I don't know why my name's on there, but I think it's you, Mike.
I don't either. Okay. We good? We all still here? Everybody? Okay. We've talked a lot about policy and procedure and assessments and checklists and things that cost money. We're going to talk now, we're moving, we're transitioning, and we're going to talk about more personal stuff. Lisa said something that she said, if you don't remember anything else, remember one thing. Do you remember what that was? Nobody remembers. What was the one thing, right? Being aware of yourself.
The energy that you bring into the room.
Right. So let's break that down for a second. In a confrontation, you need to know before a confrontation occurs, what is your limit? And I'm going to tell you my limit. If you want to punch me, I'm good with that. You want to push me, I'm okay. Kick, I'm good. Pull a knife, I got a gun. We're okay. You spit on me, we have problems. That seems to be the threshold for a lot of people. Spitting it's ugh, right? And in a lot of people, that's where you snap. If you know that's where you are, if you know that that's going to bother you, if you know that's your threshold, then guess what you need to do? Think about what you're going to do when that happens. Not if, when that happens. Someone somewhere is going to reach your threshold. And we have patients who intentionally look for your threshold. They may talk to you, well, your mother, blah, blah, blah. Or they may say something about you personally. Or they may comment on your race or your gender. Or they may comment on the glasses that you're wearing or your hairstyle. But they will get personal, they will get ugly, and I'm good with that. I'm okay with that. I've been called every name in the book. Most of it didn't even apply to me. I'm okay with that. It's that physical, intentional spit. And I've had that happen so many times, and you have to like rise above it. You have to get on that other plane, right? You're like, I'm not going to kill this person. You've got to think about that. You have to think about your awareness level. Once you come to terms with that, and I mean you personally, once you come to terms with that, then you can move beyond and start teaching others, right? Because we have to know what our limits are. We have to know what we do and how we escalate without even intending to escalate. Everybody give me a I'm angry face. Come on, give me your angry face. That's not an angry face. That's a laugh. Give me an angry face. Give me an angry face. Give me your angry face. You just did something that was horrible, and I'm giving you the angry face. How many of us do that without even realizing we do it? All right, roll your eyes. How many do that without even realizing we do? Your boss walks, this was horrible. I was on a Zoom call, and they were talking about something, and it had to do with finances, and my boss said something, and I went, oh, I'm on Zoom. Everybody saw that. Know what you bring to the table and what you're doing. Tone and inflection is everything. If you were yelling at me, what would be my normal inclination? To yell back, right? We start off calm. I don't like the way I'm being treated. I don't care that you don't like the way you've been treated. Well, you better listen to me. No, I'm going to yell louder. And that's how escalation begins. It's constant, right? Here's the trick. Your tone and inflection, and Lisa mentioned it. You do the opposite. Try it. How many of you have kids? Teenagers? All right, little kids. Do they talk to you? They're like, I want to do this. And they yell, raise their voice. Whisper. Whisper to them. What are you saying? I can't hear you. Why are you whispering? To get you to calm down. To get you to listen to me. Your tone and inflection mean everything in a confrontation. The energy you bring into the room is going to direct what happens in that room. And Lisa said it right. You want to be the person that when you walk into the room, they know things are going to calm down. They want to know that that staff that's out there and they're dealing with these idiots that they have to deal with every day, and you walk into that room and things de-escalate. But we have to teach them that. We have to be able to help them understand how we do that. So understanding all of these things is key. One other thing I want you to understand. Sometimes you can't fix it. Sometimes you're going to have someone escalating because they're escalating, because they want to escalate, because that's their goal, is to escalate. And at that point, there's nothing you can say. You can whisper all day long, and they're still going to raise their voice and yell and spit at you. That's when you take a step back. You know, you're not in a good place right now. I'm going to give you 5 minutes to relax. I'm going to give you 5 minutes to think about it, and I'll be back. Or 10 minutes, or 30 minutes, or the next 6 weeks, whatever the time frame is you want. Then step away. Sometimes your very presence is escalating the situation, no matter how good you are at de-escalation. And those people that want to escalate on purpose. Threat indicators. You need to be aware of what's going on around you. What's going on in your immediate vicinity? What are the threatening behaviors? So you and I are engaged in a conversation. If I'm standing facing you like this, that means I am talking to you. We are engaged. If I'm facing this way and talking to you this way, I'm not as engaged, am I? So if you're having a conversation with someone, and you can apply this to any setting whatsoever, you're having a conversation, and would you mind standing? Sure. So Clayton is standing, we're having a conversation, I'm talking to him like this. The moment I do this, what does this tell you? I'm now more engaged. I may have been a little engaged, now I'm more engaged. Now, thank you. Give him, he stood up. The context of the danger is what that conversation is about. So if I'm having a heated conversation and you come in and I'm looking at you and we're having a conversation like this, and then I do this, that could mean my escalation just went higher, right? So context is very important. What I do with my body is very important on how I'm standing. Okay. Failure to control position. Would you mind standing? So you're talking to me, right? And we're having a heated conversation. And I do this. Danger or not? Why?
Closer.
I move closer, and this, which is in my way, I'm now moving it out of my way. More danger? I'm getting away from this obstacle, right? Or if I simply do this, that means turn around and go away, right? That means get out. Thank you. Look at the context and what they're doing, how they're reacting. Yes, thank you. If you have a patient sitting on the bed, what they're doing while sitting on the bed is very important. If you're standing in front of me and I'm sitting on the bed, if I'm sitting back, just kind of sitting back on the bed, that's one thing. If I do this, what does it mean? What does leaning forward mean? I'm engaged. I'm more engaged in this conversation. Again, everything's based off context. If we're having a heated conversation, this may mean more of a threat. What about this? What about this? Fist clenching down at the side. What does that tell you? Right? What if my hand is like this? It's down to my side, it's not up, but it's down to my side and we're having a conversation. What does that tell you?
They're getting in the fight or flight and they're getting aggressive, ready to go.
Right. They're getting ready to go. They're sizing you up. They're looking at you. I was at an inner city hospital. I was security director there for a while. And gangs, we always had gang issues. And we were walking this one gang member out. And boy, he was just a piece of work. He was threatening. He was, I'm going to come back and cap you, and the whole 9 yards. So we're walking him out. There's 4 of us, 4 security. There's 2 in the front, 2 in the back, and we're walking him out. And I happen to be the one in the front, and he's in the middle, so he's like right here. I have him in the periphery of my vision. I'm not taking my eyes off this guy. So the whole way walking, I'm looking at him, I'm talking to him, and I can see him. He's watching me, he's looking at me. And he's looking at the other officer that was in the front. You know what he's doing? Sizing us up. The question going on in his head was, can I take him? Can I take this guy out and get away? Now, if I was just walking casually, not paying attention, that threat level would have been a lot higher, wouldn't it? So you've got to be cautious of how they're responding to you, how they're reacting to you, what they're doing as you're talking to them. That seems to be one of our issues in healthcare or in human nature, is that we're not paying attention to the response we're getting from the person we're talking to. And you can apply this to everything. The more I talk to you, the more I see whether or not you're engaged, the more I see whether or not that engagement is positive or negative. And it's based on a lot of things. But what I want you to remember is it's based on change. Here's what I mean. You're talking to someone and they're normal and they're looking off in space and you're talking to them. That's how they've been, right? That's how they've been for the last several days. They look off in space when you talk to them. Now all of a sudden you walk in and say something and they're like laser focused on you. That's a change. That ought to raise your awareness levels. Or let's say it's just the opposite. You normally walk in, I'm laser focused on you, and we're having a conversation, right? The next time you walk in and I'm not paying attention to you. I'm not listening to you. So you got to think about what's the change and why was that change, and that's when you need to start really peaking your awareness skills. What changed? Why did it change?
So one quick thing, last year I mentioned this. One of my colleagues, Katie Ann Blanchard, captain, retired captain in the military, nurse, she's a huge workplace violence advocate. She was a victim. She was managed the hospital out in Kansas, a VA, it was actually active duty hospital, but they had some civilian employees. This one employee that she inherited, who they had already told her, we got a lot of behavioral issues with this employee, and so being a new leader, she put him on that whole plan. Here's this a PIP, performance improvement, and it was terrible. He was just reacting. He never did anything. It was horrible. She did some things. She brought other people in when she spoke with him, made sure that she tried to be safer. Well, all of a sudden, he changed his behavior. For 2 weeks, he became the nicest guy, spoke to her, spoke to everybody, did everything he was asked to do, and she had this epiphany, wow, I guess I'm great. My performance improvement, plan is apparently working. Well, that afternoon, he'd been told to leave. It was Friday. We're getting ready to close the offices. She goes in with someone, hey, we've all got to leave now. And he said, okay, I'm going. The person was with her left. She goes back to her office. He comes in with a bottle of gasoline or benzene, I'm not sure exactly which, and a lighter and a knife. He poured the benzene on her, set her on fire, and then proceeded to start cutting her. And there was some folks still there, 3 individuals that came in. One was able to start putting her out. She had 20% of her body, horrible burns, and one was able to get the knife and subdue him. So it might not just be they become apathetic or they're really laser focused. All of a sudden, they may actually be super nice. It's that change that you really need to be aware of. And when you're training folks, bring up those scenarios. And just so you know, that video about that, if you think about it, Katie Ann Blanchard, nurse Katie Ann Blanchard, workplace violence, it's open access on YouTube, so you can use it in part of your training. Thanks.
Change is important. Watch for change. Watch when those movements change. Watch when those attitudes change. Okay. We bring it on ourselves sometimes. I learned this a long time ago. I was married and I said those magic words, calm down. I think it was the opposite that occurred, right? We don't say things like that. You don't be direct and say, why don't you just relax? Or what you're going through is nothing. Don't diminish what they're doing or going through, because all you're going to do is exacerbate their anger, right? So here are some other things that you can say. May I talk to you? What can I say? How can I help you? Things that are not the judgment. And then watch for change. Conflict triggers. Look for those things that either they've happened in the past, and this is why conversation between clinical staff is very important. We may have a patient that the previous shift, we found out the conflict trigger. Well, if we don't communicate that to the next shift, we're just setting them up for trouble too, aren't we? So we've got to be able to communicate to each other what these triggers are, what these hot buttons are for that patient. Had a patient, bless his heart, he was calm. He was almost frighteningly calm. You ever get that feeling from somebody? Right? Just under the surface, there's a volcano about to erupt, right? But when I was in the room, he was calm. He hated women. I mean, it was palpable. It was, you could see it. And we all got the word out, right? He hated women. We're going to, if there was a female nurse or physician that was going in, we're going to make sure there was a male present as well, but we were going to try and make sure it was male going in and attending to this person. Well, they didn't get the word out to everybody. And she was a dietitian. She was just going to go in to check on the food. And she walked in and he threw a fit. He picked up a chair, he threw it at her, hit her. It did some damage to her arm, but she was completely aghast. What happened? What's going on? I don't understand. And she was frozen in fear. She couldn't scream. She was so frozen in fear. The only reason she got help is because someone heard the chair hit the wall. And then they realized, oh, that's Mr. So-and-so. Let's get in there. So we have to be able to communicate to folks, and we have to be able to say, these are the triggers. These are the things to watch out for. You know, we post signs when someone has an airborne transmittable disease, right? We post signs when there's a droplet precaution, right? Do you ever think about posting a sign that says, warning, this guy's a nut job and will be violent? Okay, let's not do the nut job part, I get it, but violence. We need to have violence warnings on folks. Think about that when you go back to your facility, and think about what can we do to alert staff that this person has triggers. So think about that. Self-prep. Remember, we're talking about ourselves and knowing us, knowing our limitations. So I saw this on a long time ago, and I think it's amazing. It's about making yourself ready. Disney, I had a friend of mine that it was a friend of a friend, and he was in charge of security down at Disney in Orlando. And I got to tour, and I went down and I talked to him, and I said, what do you do to prepare? And I want you to think about this for a second. You're an employee at Disney, the most hated place to work in this universe because of children and their parents. And you have to deal with that crap every day. How do you prepare to do that? How do you get into character? How do you get into a costume and go out there and some little 5-year-old is punching you in the gut every 5 minutes? Some parent is complaining that you're not there enough, and you're getting it from all sides. And this is what I was told. It's called being in the moment, being on stage. When you get ready to go into a patient's room, you remember I said earlier, before you knock, what do? Listen. How long you listen for? 5 seconds. What are you doing in those 5 seconds besides listening? I know this patient is a pain in the... We're preparing ourselves to go into this room. Okay? Get yourself ready. Take a deep breath. Take 2 breaths. Tell yourself you're ready, you're capable, and you can walk into this room. You've got to do it. Just thinking it, pretending it doesn't work. Do the Superman stance. You ever see that? Everybody stand up. Stand up. Stand up. Stand up. Oh, he's making us stand up. Oh, gosh. This was a sitting class. All right. Arms on your hips. Head back. Shoulders back. Breathe in and hold it. Let go. One more time. Breathe in. Let go. I got this. I got this. Now sit down. If you don't feel better, you're just, I don't know, strange. You're weird. Hopefully you do. Hopefully you feel better. Hopefully that is a trick that will help you get through a lot of stressful moments. You're going in for a job interview. You're going in for some type of meeting that you've got to present. You're going into, I don't know, doing one of these dog and pony shows, right? You breathe. Let it out. You're about to have a conversation with someone that you know is not going to go well. It could be an employee. It could be a coworker. It could be your boss. I got this. This works. And if we're able to do this in a couple of seconds, we'll be better prepared and more alert to what's going on around us in those rooms, in those conversations. You're about to term someone. HR, I love HR. Anybody HR? Who's HR? I know there's an HR person here. She's like, don't call on me. Don't pick on me. I'm HR. Okay. I'm not going to pick on HR. Yes, I am. When you terminate someone's employment, I want you to think about that. How do you do it? You don't have to answer. Don't say it out loud. Do you do it in the confines of your office that's tucked away in the middle of nowhere and the nearest person is like a half hour away? Do you do it on the patient floor? Do you do it in a conference room? Do you do it with someone to witness it? I need you to remember this. I hear this all the time. Do you want security there or nearby? No, I know this person. No, you don't. You do not know the individual that you are counseling or terminating, because what you're doing is about to impact their ability to put food on the table and a house or roof over their head. You don't know what that's going to do. You don't know what's going on in their home. You don't know what your conversation is about to invoke. So you need to be prepared for the worst. And then if all that happens is they cry and you pat them on the shoulder, give them a tissue, and escort them out, okay. But you need to make sure you're ready for the violence. You also need to make sure that you're ready for the violence that may come days later. I have a situation going on right now that I won't tell you where, but we had a patient 2 years ago. 2 years ago, this was a patient. He came back to the hospital and he wanted to talk to the nurse manager and he wanted to interview all the nurses on the unit. So he talked to the nurse manager. I want to interview all your nurses. Why? What can we help you with? I am convinced that when I was a patient, you let the FBI come up to my room and they forced me to watch child porn. So now we know we're dealing with a really sane person. She was very diplomatic. She said all the right things. He kept calling. He kept leaving emails, sending her emails. And then finally, he left a message that was one of those vague, I'm not directly threatening you, but I'm going to say something that you will perceive as a threat. So then she got scared and she calls us. What do I do? So it may not just happen then. It may happen years later. The biggest thing about that is, if it happens years later, that very first contact years later, you need to be throwing up the flag. 2 years ago, this guy was a patient. Now he's telling me the FBI came in and watched him watch child porn. Ding, 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 right? Red flags should have gone off everywhere about this instead of let's just let it ride. Let's see what happens. We got law enforcement involved. We did a lot of different things. He actually was arrested for another situation that he was involved with, and now he is in a behavioral health center. So things happen, right? You just got to be mindful and don't ever think, well, the person in charge of security is too busy for this. This is just nonsense. I would much rather we take some proactive steps at the moment than be responding later on down the road. Okay. We talked about the hello doctrine, the greeting. It's all about the verbals and the nonverbals, as Lisa had talked about, right? How you approach someone, what you say. How you doing, sir? How are you doing? How's your day?
Good.
Good, good. Couple of things I want you to notice about that. What did I do? I leaned in, weights on this foot, shook his hand, right? There's enough distance where I can pull back, and I've got weight on the right foot where I can pull back very quickly. If you're just having a conversation with someone, how are you standing? You're in a stance. right? Feet shoulder width apart, a little bit of an L where you can move and groove and go in different directions. It's all about your approach, how you approach someone. If I walk into a patient's room, yeah, I see here on the chart, crap, I got to do another IV or blah, blah, blah. What are you conveying in that sentence? You don't care, they're a pain, and you're a problem, and you're forcing me to work when I could be in the back playing, I don't know, whatever game's current on the phone today. Right? It's be careful how we're doing that, how we're engaging with everyone. Remember I said earlier, you need to be able to accept that you can't change everybody? So there comes a point where you're trying to persuade someone to act differently. And you've got to realize, even after you've given options, even after you've given them the opportunity to reconsider, you have to understand that there's a moment where even the best of negotiators is not going to calm someone or get someone to do what you need them to do. At that point, you need to know, what is your next step? What are you going to do then? And sometimes we forget about planning for that part. What if we can't de-escalate them? What if we can't get them to cooperate? What are we going to do? Both from a clinical standpoint and from a human management standpoint. What are you going to do with them? Own your response, that's spitting, right? You got to make sure you own that response. When someone comes at you and you respond poorly, that's on you. You're escalating that situation, and you got to own that. Yes, we do have clinical folks who don't do that very well. We have everybody. There are lots of people in every group who don't do that very well. And that's where we need to step in and help them. I was part of a team that did hostage negotiation. We were doing a drill, and it was a very lifelike drill. This was years ago. And I was horrible. I was the worst. If you wanted to see everything to do wrong, you put me there, right? That's how bad I was doing. And I was messing up, and they taught us that when you're messing up, if you don't realize you're messing up, your partner needs to realize you're messing up. They can tap you out. But here was the key thing. I needed to understand that if I'm being tapped out, it's not personal, and there's something happening I'm not seeing. Does that make sense? So you and I are de-escalating this lovely Susan, right? Susan is just off the charts, and she's crazy, and I'm talking to her, and it's escalating, right? My whispering went out the window. We're yelling at each other. So when Clayton comes up and taps me out, I have to understand, time to shut my mouth, back out, and let Clayton take over. And we have to realize that. But if you don't prepare people in advance, right? Like if Clayton just noticed, Mike, you're horrible at this. you're not doing very well at all. In fact, you're making it worse. And he taps me out. What's my response going to be? Hey, don't bother me, right? I got this, because now my ego's involved, right? I got this problem. I'm fixing her. No. So teach people how to tap out or be tapped out. And then when to call for help. Remember my 6 aunts? All nurses, right? They are all type A personalities. Thanksgiving. Type A personalities, right? Clinical background. I got this mentality. Mike, what is it you do for a living? Security, emergency management for hospitals. Well, in my day, we didn't need security. We handled it on our own. We just thump them. Okay, I got you. But when that person outweighs you by 200 pounds and several feet, what are you going to do? And it's that mentality, right, of I don't need help, so I'm not going to call for help. So we have to teach people it's okay to need help. It's okay to feel as though things are getting a little out of control. So when you start injecting these thoughts, when you start injecting this into your training, when you start injecting this into everyday situations, that's when it becomes really effective and impactful. Okay, great way to break stress is humor. Think about how we're up here and we're talking to you. We're trying to gain your attention and we're trying to gain your engagement. We use humor, right? We talk about funny things. I say stupid things up here and you kind of chuckle, right? You laugh a little bit. It gets more engagement. So when you're doing it one-on-one, in those types of situations, empathy and humor go a long way. I understand how you're feeling. I can't believe what you're going through. I want to empathize with you.
The other thing that's kind of the rule, those of you that have taken, I think I spoke with one person who'd actually had the verbal judo back in the day, and one of the things that you really learn is never show and never take anything personal. Never show your personal face. It's not about you. It's about the situation. It's never about us. No matter, our face may be the one they see and they can make fun of, or they can say the things about where we work or what we do, and it's really difficult. I can say that, but it's never use your personal face.
I work for a guy that crunches numbers and does money. So, why are you here? What did you get out of it? What is the return on investment? And why should we do a workplace violence prevention program? What's our return on investment? Why should we spend money that we don't have on de-escalation training, right? Well, let's look at these. People who feel safer in their place of employment are more engaged with what they're doing versus worried about being safe. Can we agree on that? There's studies that show that. People who are more engaged in what they're doing make fewer mistakes. Can we agree on that? There's studies on that. People who are more engaged in what they're doing care more about what they're doing. Can we agree on that? So if we have a staff that's more engaged, they care more about what they're doing, they're making fewer mistakes, what are we getting? Better patient outcomes. If we get better patient outcomes, we get better reviews, right? We get happier patients. We get happier patient family members. We get fewer incidents of, why are you not taking care of my mother? Right? There's your return on investment. You want to start looking at injury claims and associated costs, safer staff. You want to start looking at the non-tangibles that we don't normally equate to violence, that are offshoots of violence. Look at workers' comp claims, look at your retention, look at your turnover. Those are your return on investment. So when you spend a day here, and then you go back to your facility and you start looking at things that you want to implement, it could be, honestly, if you walked out of here and you started with the hello doctrine, or you started with the 2 minutes with the cards every day, that's a huge step in the right direction. You start engaging more, you get with the hospital association, and you say, hey, this was great, here's what else we would like. Or you look at their website and you look at the resources that they're providing you, and you comment on the resources and you say, you know what, that 106-page assessment guide is ridiculous, but it helped me when I was vetting a contractor. Right? Or the little 3-pager helped me out great. We want more of that. That's where you get your ROI. Right? Take this and turn it back around. I want to thank all of you while she's walking up here. I want to thank all of you for coming out, spending your time. I know it's a pain in the butt to get in your car and drive and travel and be here and sit in that chair all day long. So I appreciate you. So thank you very much. Give yourselves a good hand.